here, and I thank everyone a lot, especially Dr. Dharmendra sir for giving this opportunity. Thanks a lot.
Dr. Abdullah, you can say the Shruti, our youngest,
Sorry to interrupt, sir. Sorry to interrupt, sir. We are live.
Okay,
Yes, sir. I am starting the session, sir.
okay.
Good morning, everyone. I welcome you all to the Unlocking the Secrets of Spinal Trauma. I request the organizers to kindly begin the proceeding. Over to you, Dr. Dharmendra, sir.
Yeah. Welcome, myself, Dr. D.K. Singh, Secretary of MSS India. I welcome Dr. Abdullah Al Rahmati, President, Radiological Society of Emirates, Dr. Jayaraj Govindraj, sir, President, Muscular Society India, Dr. Vijay Papineni, President, Emeritus Club of MSK Radiology, dear eminent speakers and delegates. Welcome to today's webinar on unlocking the secrets of spinal trauma, brought to you by the MSS UAE collaboration. We are gathered here to delve into crucial insights and advancements in the field of spinal trauma, aiming to enhance our understanding and improve patients' outcome. So let us begin our exploration into unlocking the secrets of spinal trauma. I, uh, I, I invite Dr. Abdullah for some opening remarks. Dr. Abdullah, President. Yeah.
Thank you very much, Dr. Singh. Good morning, everyone. Dear Dr. J. Raj, the President of the MSK Society in India, our distinguished speaker, my fellow radiologist in India and UAE. It's gives me such great pleasure and honor really to be here and to welcome you to the first MSK webinar in collaboration between the MSK Society of India and the Radiological Society of the Emirates and the MSK Journal Club in Emirates. This is nothing but the natural process and progress of our distinguished relation between the two countries and the friendship that's not only at the present, but it's go back centuries of historical distinguished relation. And I wish that this will be the beginning of more and continuous collaboration between the two societies for the benefit of our young radiologists in the two countries. As you are aware, this is very progressing and fast growing field, and the update from our distinguished speaker to everyone is highly appreciated. I don't want to take more of your time, but I want to take this opportunity to thank Dr. J. Raj, the President of the MSK Society of India, Dr. D.K. Singh, the Secretary of the Society, for their distinguished work and for their effort in making this collaboration successful. I would also like to thank my colleagues, Dr. Vijay and Dr. Rashid Sharhan and their colleagues at the MSK Club for putting the effort for this to be successful. And I wish you successful event. Thank you very much.
Thank you. And now I invite Dr. Jairaj sir to please give some opening remarks.
We in India are very, very excited about this particular webinar, and I'm sure this interaction with the two societies will grow far and further. I wish this particular webinar all success and look forward to having many more of the same. And I request DK, please proceed with introducing the other people.
Yeah. Dr. Vijay sir, please give some opening remarks.
Good morning, everybody. Welcome you all to the first inter-society webinar between UAE and Indian MSK Society. This is a very, very exciting, very excited about this program and connecting with Indian society. This was an idea that I got, and I had a chat with Dr. Singh, who was very excited, and he was the one who took this opportunity to collaborate and did all the groundwork we came up with the idea that spinal imaging would be useful for most of the, not only the MSK radiologists, but general radiologists. So we selected this topic, and this we have very distinguished, excellent speakers from both societies, which I hope will enrich everybody's knowledge, and I hope this knowledge sharing platform between both societies, our friendship will expand in the coming years, and really excited to be a part of this initiative. I thank Dr. Singh and Dr. Jairas for facilitating this, and I also thank all the speakers for participating. Without taking more time, I would like to go ahead with the program. Back to Dr. Singh.
Yeah, Dr. Seta, back to the first speaker. Okay, can you take online the first speaker, please? Yeah, Dr. Vijay, please introduce the speaker.
Right. Dr. Rashid Al-Shad is a MSK radiologist. Currently, is working at Dubai Health. He is a MSK radiologist working at Rashid Hospitals. He's also program director for the residency program, and he also works with the Muhammad bin Rashid University. He's a Canadian board trained MSK radiologist at McGill University. And he also got fellowship training from University of British Columbia. He has a special interest in medical education, artificial intelligence, MSK, and trauma imaging and minimally invasive procedures. Today he's going to talk about the spinal trauma, role of X-rays. Dr. Rashid.
Thank you, Dr. Vijay, for the introduction. Let me set up my screen. Okay, so is my screen visible?
Yes, sir. Please proceed.
Perfect. Thank you. So good morning. Assalamu alaikum, everyone. I would like to thank the organizing committee for the kind invitation. And I'm very much excited to be part of this group of people presenting and educating our young generations. So today I'll be talking about the plain film assessment in spinal trauma, navigating this landscape. So my outline would be as following. I'll start with an introduction. I will talk briefly about spinal anatomy. We'll talk about trauma mechanisms and causes of traumatic injuries. Then we'll discuss some classification systems. I will have a few cases for discussion and as examples. And finally, we will mention a few take-home messages. So the trauma affecting the vertebral column and spinal cord has a variety of severity. It can be very mild with soft tissue contusions and reaching very severe to cord transaction. And those injuries, they can have significant implications in terms of morbidity and patient's mortality. So as a radiologist working in trauma settings, if you come up with a fast and accurate diagnosis, this will help in timely patient's management. So there is a burden on health outcomes, and according to the World Health Organization, almost up to 500,000 people suffer spinal cord injuries worldwide each year, with the rates are variable between different regions and socioeconomic factors. And these injuries can result in either permanent disability, reduced quality of life, substantial healthcare costs, and of course, some of them result in complications leading to death. So what is the role of radiographs in the diagnosis? So as you know, with the advancement of imaging technologies, the role of radiographs becomes more limited. Some of those limitations are related to
Sir, sorry to interrupt you. Can you please
Yes.
move closer to the system, sir. Your voice is a bit low.
Okay, sure. Do you want me to use maybe headphones?
Just try moving close to the system, sir, and
Okay,
continue.
what about now?
Yes, sir, it's audible.
Okay, so the role of radiographs in the diagnosis is limited. This can be limited because of the patient positioning. Most of those patients are sitting in the trauma bay and they cannot be transferred to other places for radiographic imaging. But it is an important initial imaging modality because it is widely available. It is relatively cheap compared to other imaging modalities, and you can provide a rapid evaluation, especially if there is a large or very obvious trauma or traumatic injury. It is useful in some cases, for example, for screening. It is good for finding fractures, but it is not good for subtle fractures and ligamentous injuries. It is good for the spinal alignment and for evaluation of or quick evaluation of spinal instability, especially with the flexion extension views. And finally, it is a good baseline examination for follow-up, especially if the patient undergoes surgical intervention or conservative management. It is important to remember that, like with any other musculoskeletal or radiographic imaging, it is important to have a second view or second plane for further characterization and better evaluation. Although soft tissue is not a reliable sign, soft tissue swelling is not a reliable sign, but it is always good to evaluate for it. And then if you are suspecting or the clinician is suspecting a ligamentous or spinal cord injuries, the normal radiographs doesn't mean anything. We need to proceed with further imaging by CT and MRI. And in cases of cervical spine injuries, always remember to add or recommend CT angiography of the arch to vertex just to evaluate for associated vascular injuries. This is it shows you the value of the second view. And as we say in imaging, one view is no view. So anatomy overview, as you know, the spinal cord is divided into 5 segments, cervical, thoracic, lumbar, sacrum, and coccygeal. The thoracic, lumbar, and the lower cervical, they share the same structure with a body, pedicle, posterior elements, while the C1, C2, sacrum, and coccyx are special vertebrae, where the C1 has its vertebral body as part of the odontoid process of the C2, while the C1 is supporting C2 for the axial rotational movement with multiple associated ligaments. And then when we look at the radiographic anatomy, as you can see, this is a lateral neck radiograph, and it shows that these are the areas that we are looking at, the different vertebral bodies, the different posterior elements. It is very important to pay attention to the distances between the vertebral bodies, which is occupied by intervertebral discs, the distance between the articular processes forming the facet joints, and to pay attention to the spinous processes as well. As you know, there are different lines that needs to be evaluated and assessed on every lateral neck radiograph. So first one is the line crossing anterior to the vertebral bodies, which is called the anterior vertebral line, and it can be a representation of the anterior longitudinal ligament. The posterior vertebral line is also representing the posterior longitudinal ligament, and then there is a line between the posterior elements, which is the spinolaminar line, and finally we have the line along the spinous processes, which is the posterior spinous line. Any abnormality of the alignment of any of those lines should alert you to look further at that level and then possibly request additional imaging to further evaluate it if no radiographic findings are visible. For the soft tissue swelling, a rule of thumb that we teach our trainees that at level of C2 it shouldn't be more than 5 or 7 as in this image here, and at level of C5 shouldn't be more than 22. Here they used 2 and 7, but the concept is the same. There shouldn't be soft tissue thickening more than 5 to 7 millimeters in front of C2 because that area is only occupied by soft tissue mucosa, while in C7, C5, C2, C7 level, there is the esophagus as well. So that's why it shouldn't be more than 2.2 centimeters. What is the value of flexion and extension? As you know, in the settings of trauma, the patient will have other injuries with distracting pain, and they might not be able to do those maneuvers of extension and flexion. However, if the patient is able to do it, any translation of more than 2.5 to 3.5 millimeters is a marker of instability. What are the causes of spinal injuries? Most are related to motor vehicle accidents, which are either related to the accident itself or the improper mobilization due after the accident. Other injuries like fall from height, sport-related injuries, penetrating injuries, and gunshot wounds are also culprits in the spinal injury causes. In terms of mechanisms, after analyzing any injury, we can either classify it as multi-mechanism, or we can choose one of those. It is either hyperextension, hyperflexion, compression, which is also known as axial loading, rotational, lateral stress, and distraction. And some of the patients, especially in the setting of motor vehicle collision, they can have multiple forms of those injuries. Which classification system to use, or which classification system is the best? Is it the Asia Impairment Scale, AO Spine classification, Frankel classification, TLICS, SLIC, Dennis? So the answer is, it depends on many factors, including what is your question? Are you a clinician looking for impairment, or are you an orthopedic surgeon looking for, or neurosurgeon looking for spinal fixation? So those three classifications, Dennis, AO, and TLICS, those are concerned about the fracture characterization. As you know, Dennis looks at the 3 columns, and as you progress involving the posterior column, the stability reduces and it becomes more unstable. The AO classification, it classifies the fracture based on the type, location, and the severity, and there are different grades. And the TLICS is the one that is concerned with thoracolumbar injuries. And again, it classifies it according to the fracture characterization. And all the 3 are helpful for operative plan, or for the planning of the management, either operative, conservative, or combination. The ASIA is the one that is more clinical and classifies the injuries based on the sensory and motor function. Similarly with the Frankel classification, which adds, which is a simplified classification looking at the neurological deficits and motor function. And the last one is the SLIC, which is used for a specific subgroup, which is the subaxial cervical spine traumatic injuries. As you know, and as we discussed earlier, what is the best classification? The answer is none, because it depends on what is your question. Are you a clinician looking for the deficit, or are you a surgeon looking for fixation? Now we will move to discuss some of the cases and examples. All the cases are they presented as motor vehicle accidents. Starting with the first case, I'm providing you with the frontal and lateral radiographs. I will pause for a bit. Okay, so I hope that you are able to pick up the finding here, where there is a small, let me have my laser pointer. So where there is a distracting fracture injury here at the C5 anterior inferior corner. In addition, there is soft tissue swelling anterior to C2. And then there is here, if you look at the alignment, if we draw our posterior line, vertebral line, you will see that there is a step deformity here. So this is a C5 flexion teardrop fracture. So this fracture type is considered unstable and needs urgent fast surgical referral. So those injuries, the flexion injuries, they can happen in sport settings, in trauma setting, in the motor vehicle collisions, and others. And it is characterized by severe hyperflexion injury of the neck. And there is a spectrum of findings. They can either be just a distraction with hyperflexion sprain, and then this is considered relatively unstable. Then we have the simple teardrop or wedge-shaped fracture. This is considered stable if it involves the posterior elements with the posterior interspinous ligament. This becomes unstable, and as it becomes unstable, there will be more disc injury and spinal cord injury. And the last one of them is the flexion teardrop injury, which is, as the case that I showed, it involves the fracture, involves the alignment abnormality, and the posterior element injury. This is another image showing the same findings. Usually there is distraction and fracture of the anterior inferior corner, ideally of the lower cervical spine, C4, C5, C6, C7, and there is abnormal alignment with retrolisthesis of the upper level compared to the one below it, and there is distraction of the facet joint as well as injury to the posterior element. So as you can imagine, like the entire column is disrupted, starting with the anterior elements, middle, and the posterior elements. Usually those are highly unstable and needs urgent attention. I will skip this slide here. As I mentioned, you need the combination of those findings in the lower cervical spine to come up with this diagnosis. What is your next step? As you will see, this slide will repeat itself in multiple cases. You need MRI for further evaluation, especially to evaluate the cord itself and involvement of the disc injury or intervertebral disc injury in the above and below levels, as well as to assess for ligamentous tears. Then you will need to suggest and recommend CT angiography for vascular assessment, especially those injuries, they occur in the area of the course of the vertebral arteries and the carotid arteries. And finally, you need to recommend urgent spine surgeon referral. The treatment and prognosis of those is variable and depends on the degree of injury. If it is just soft tissue, as in the first example, then the prognosis will be relatively good, but they can result in significant neurological deficit and quadriplegia. Most of those, they will need decompression and internal fixation, regardless of the degree of the cord damage. So our patient here went to surgery, they got reduction and then anterior fixation at the level of the injury. What is our pitfall? These fractures are usually confused with the extension teardrops, especially for young colleagues. What are the differences here? As you can see, with the extension teardrops, they usually are in the upper cervical spine. Usually it involves the anterior inferior corner without listhesis of the spine or abnormal alignment, and usually the posterior element is not involved. These are less severe and they can be managed conservatively. So this is a diagram from Radiopedia showing the comparison between the two in an illustrative image. Usually the extension, it involves only the corner ALN injury, but it will not propagate posteriorly, while the flexion, it involves the three columns or the entire cord at its axial extension. Moving now to the second case. So I will pause for a second. So I hope that you saw the abnormality at the lower cervical spine where there is a step deformity with anterior listhesis of the spine. This is a CT representation just to show you the additional finding together with the listhesis. So here is the listhesis, but when you look at the both sides, you see that the facet joints are also dislocated and they are locked. So this is described as facet dislocation, and those are locked facet dislocation. Usually, this is a very unstable flexion distraction type of injury, and there is usually complete ligamentous disruption. The facet joints are also disrupted, and then there is abnormal interspinous distance. Those are usually associated with spinal cord injuries and vascular injuries in the cervical spine region. And they need, which is a must, MRI for further evaluation, CTA for the vascular assessment, and spinal surgical evaluation. And as you see in this case, the patient got reduced under GA, and then the anterior got anterior fixation. Retrospectively, now you can see that there is a fracture here in the spinous process at this level. Moving to the next case. So here I'm providing you with frontal and lateral as well as the open mouth view. So I'll pause for a second. So I hope that you are able to come up with the finding, which is only seen on the open mouth view, where there is a fracture of the odontoid here. There is distraction of the cortex, as you can see here. The distance between the lateral mass of C1 and the odontoid is preserved. You can see here, this is the companion CT of that patient. It shows the fracture extending into the body of C2. Odontoid fractures, they don't follow the earlier classifications. We use this classification, which puts it in 3 categories, type 1, 2, and 3. For type 1, it is only fracture of the upper tip of the odontoid process. Type 2 is through the base. Type 3 is through the base and involving the lateral masses. Type 3 has the best prognosis and is considered relatively stable, while types 1 and 2 are unstable injuries. This is the management planning for them, and usually they will need surgical fixation unless the patient opts for conservative management where they put them into the neck brace. As usual, MRI is needed for further evaluation, CTA for the vascular assessment, and spinal surgical referral. This is an interesting case where the patient had a trauma, which was described as minor, like fall from very short distance, in a patient with known in a patient who is known with a chronic condition. So looking at his previous radiographs, you can see this frontal lumbosacral radiograph. I'll pause for a bit. So I hope that you were able to spot the diagnosis which this patient had before coming to the hospital. So there is ossification of the interspinous ligament here. There is fusion of the sacroiliac joints. There is syndesmotic calcifications and ossification here. So the combination of the finding is of ankylosing spondylitis, where there is the dagger spine. So these are the syndesmotic ossifications, fused sacroiliac joints. This is the dagger sign, and this is the bamboo spine. So those patients, even if they come with minor trauma, usually they will have the distracting back pain, but you need to image the entire spine at every time they have any trauma. So this patient complains of diffuse spine pain. What shall we do next? So X-ray was difficult in this case, and due to the background ankylosing spondylitis, the decision was to proceed with full spine imaging. This is an accompanying case from a different patient that shows you that this is a bamboo spine. It is an entire one segment of the spine, and there is a fracture at this level here. This is our patient. We have a similar fracture at the lower cervical level. It is actually at the cervicothoracic junction between C7 and T1. So this was a complication of ankylosing spondylitis with a fracture secondary to a minor trauma. Usually, the spine is, although it might seem that the spine is fused and like strong, but it is a very weak spine. And usually it happens at the junctions of the cervicothoracic or thoracolumbar and usually it fractures as a carrot stick or a chalk stick, and you need the following for further evaluation. This patient underwent surgical fixation with posterior spinal fusion. Next case, I'm not sure what is the time. Do I still have time or? Okay, I'll keep going until you stop me. So this patient, the next one was found under a bridge. This was his ankle imaging, CT. As a reflex, your next step should be evaluation of the thoracolumbar junction. So this patient had a radiograph which was portable, but the area of concern was not included in the imaging field. While here on the lateral view, you can see that there is abnormal height reduction of L2. So you can see it here, but the L2 was not included in the, L3 was not included in the radiograph. So as you can see here with the CT, that there is a burst fracture of this one, L3, with posterior extension, retropulsion. And usually those injuries are described as lover's fracture, where there is comminuted ankle injury. And your reflex should be always to recommend spine imaging to evaluate for burst fractures. Usually it is a component of axial loading, similar mechanism to Jefferson's, and usually those are unstable because of the associated retropulsion that can result in coda-equina syndrome or cord compression. Next, and I believe this is the last case, I will pause for a second. So here you have frontal and lateral radiographs. You might argue that there might be soft tissue swelling at this level here in front of C2, but otherwise the alignment is preserved, no fracture is visible, but the patient still had neck pain. So they were thinking maybe it is C1, C2 fracture. They looked carefully here on the provided open mouth view, nothing was visualized. So normal was the report, but as you know, normal is an illusion. What is normal for the spider is chaos for the fly. So the next step here should always be further imaging with cervical spine CT and then maybe subsequently MRI. So usually I start with my sagittal view here. There is nothing on the sagittal view, but looking at the both sides of the images, you see a small chip fragment at the occipital condyle. So this is a very important injury to be recognized, and usually those are very subtle on radiographs and almost impossible to pick them up based on the positioning of the patient. So these are the fractures. So occipital condyle fractures, they usually result from high energy blunt trauma, and you need to recognize them to help with the subsequent management. Usually those are classified into three types. Type 1, it is the comminuted fracture of the occipital condyle. Type 2 is the one that extends into the base of the skull, and type 3 is the avulsion, like in the case that we are looking at. So type 3, it is a potentially unstable injury and needs urgent evaluation. So by that, I come to the end of my talk. Things to remember, in my point of view, the concept of the spinal cord injury without radiographic abnormality. So if you suspect that, you need to recommend further evaluation with MRI to evaluate for ligamentous and cord injuries. Radiographs are important, but you need to know and convey to the team that they are limited. And if there is suspicion for subtle injuries, you need to go for further evaluation by CT and MRI. For subtle fractures, again, CT and MRI is superior. CT angiography is important to exclude accompanying vascular injuries, which is usually in the cervical region, but it can also occur at the aorta where there is a dissection next to a burst or chance fracture. You need to ask for an urgent neurosurgical evaluation, especially if you are describing an unstable injury. Although useful finding, prevertebral soft tissue swelling is not always present, and it is limited if there are tubes and lines, especially ETT and feeding tubes. These are some references. Thank you for your attention, and this is my LinkedIn barcode if you would like to connect. Thank you.
Dr. Rashid, thank you for the excellent talk on the plain film imaging of the spinal trauma. I will leave the Q&A to the end. We are running a bit late. So I will ask Dr. D.K. Singh to introduce our next speaker, Dr. Shruti Subramanian.
Yeah, Dr. Shruti, welcome, Dr. Shruti Subramaniam. Yeah.
Thanks a lot.
Okay, Dr. Shruti Subramaniam is a very promising and dynamic MSK radiologist from Apollo Hospitals, Kochi, India, and she's consultant in Astro Group Hospitals and very passionate about the MSK radiology. She is the coordinator of our daily interesting cases, that is MyCord, and we are proud to have Dr. Shruti as one of the active member of Vascular Society India. She have won, I don't think she have won the very medals, I think, 2021, 23, and much more. So, Dr. Shruti is talking about some role of CT in spinal trauma. So, what, Dr. Shruti?
Thanks a lot, sir. Thanks a lot for the introduction. Is my screen visible, sir?
No, ma'am. Please share your screen. You have to share.
Is it
Now
visible
it's
now?
visible, ma'am. Please put it in slideshow mode and please proceed.
Yeah. A very good morning to everyone. I'm very thankful and blessed for this wonderful opportunity in collaboration of Society of Emirates and Indian Musculoskeletal Society. So today I'll be talking about CT in spinal trauma. It is important not just because of the structures involved, but also because of the complications which affect the spinal cord, mainly seen in the age groups of 20 to 50, predominantly in the males. So it occurs in thoracic and lumbar levels predominantly, but I will concentrate on cervical spine as it has a majority of complications which occur. So CT is commonly used for evaluation after X-ray, as Sir had already mentioned. We can evaluate the integrity and the fracture fragments, the type of fracture, and the localization of the fragments can very well be determined with the help of CT. Now, according to the Nexus criteria, they say that spinal imaging, that is cervical spinal imaging, is not indicated if all the 5 of these criteria are met, which includes no distracting injury, no altered level of consciousness, no intoxication, no focal neurological deficits, or no midline spinal tenderness. So coming to the cervical CT imaging, the cervical collar has to be in place for the patient while the imaging is being done with the head directly over the CT table without a head holder or pillow to avoid flexion and to maintain a neutral position during the imaging. To avoid a search pattern error, it's always very helpful that we have a checklist in mind. So I will talk about the different sections and the checklist. Like in transaxial images, we have to have a look at the integrity and the rotational alignments, the cervical soft tissues, the spinal canal diameters, and the intact osseous ring, which has to be present around the spinal cord. In the midline sagittal images, we always have to have a look at the anterior spinal line, the posterior spinal line, the spinolaminar line, as was already mentioned for the X-rays, as well as the bastion dense and the atlanto-dense interval. The bastion dense interval has to be less than 9.5 mm and the atlanto-dense interval has to be less than 3 mm. In the parasagittal images, we have to look at the bilateral atlanto-occipital articulations or the atlanto-occipital intervals, which has to be no wider than 1.4 mm. And it's very important to have a look at the facet joints, which has to be parallel and it shouldn't be wider than 2 mm. On coronal images, we have to have a look at the occipital condyles and the alignment of C1 and C2. And the distance between the C1, that is the lateral masses of C1 and the otolite process, has to always be lesser than 7 mm. Then this is the basic anatomy as was already covered by in the previous talk, wherein we have the odontoid process, the lateral masses, the transverse process, the articular processes. On the axial view, we have the superior articular process, the transverse, and the posterior and anterior arch of atlas. Because C1 and C2 are the atypical vertebrae, whereas C3 to C7, the typical vertebrae, we have the body with the lamina, spinous process, spinal canal, etc. So this is another video representation of what we see, the facet joints, the lamina process, the spinous process, and the vertebral body. So again, emphasizing on the atlantodense interval, which should not exceed 3 mm in adults, and in children less than 8 years, it shouldn't extend more than 4 mm because of the increased ligamentous laxity in children. Now, how do we determine stability in cervical spine? Is by the integrity of the skeletal components as well as the ligamentous structures and the apophyseal joints. Now, what are the important ligaments of the spine? Are the supraspinous and interspinous ligaments, the posterior longitudinal ligament, and the ligamenta flava. So this is a diagrammatic representation of the ligamenta lucae, the posterior longitudinal ligament, anterior longitudinal ligament, the discs, the vertebral bodies, the supraspinous and interspinous ligament, which maintain the integrity of the cervical spine. According to Daphner and colleagues, they divided the cervical spinal injuries into major and minor categories. The major category is either having a radiographic or CT evidence of instability without associated neurological findings, whereas minor injuries have no evidence of radiographic or CT instability features, and they have no neurological findings. Now, how do we categorize an injury into major category? It is based on the displacement of the fracture fragments more than 2 mm in any plane, widening of the interspinous or interlaminar spaces, widening of the facet joints, disruption of the posterior vertebral line, widening of the disc space, hangman's fracture, fracture of odontoid, and type 3 occipital condyle fracture. Now, in the coming slides, I'll be discussing about the different types of fracture from cranial to caudal, their importance, the mechanism of injury, and the complications thereby. So if we broadly categorize them, the mechanism can be flexion, extension, and compression kind of injuries. The unstable injuries in flexion being occipitocervical dislocation, bilateral facet dislocation, type 2 odontoid fractures, or teardrop fracture. In extension injury, again, it's occipitocervical dislocation and hyperextension fracture. Compression, C2 Jefferson's fracture is a very important fracture, which is unstable. Shearing injuries, the lateral dislocations are unstable. Type 3 occipital condyle fractures in rotation injuries are unstable. So first entity, atlanto-occipital dissociation, I'll be just running through the different types of fractures and their mechanisms and their complications, and how do we see them on imaging. So it mainly occurs because of distraction combined with flexion or extension, which causes the craniocervical ligament disruption. They're accompanied by severe neurological deficits. Now, what do we need to see in this injury is mainly the atlanto-dense interval as well as the basion-dense interval, which has to be less than 9.5 mm, and the atlanto-occipital intervals has to be less than 4 mm, 1.4 mm. So in this image, we can see that the basion-dense interval is increased as well as the atlanto-occipital interval is increased, which signifies the presence of dissociation. Next, talking about the occipital condyle fractures. They are very rare and they're often overlooked. So we have to look at them with a very high index of suspicion when we are suspecting, and we have to see them with coronal reformations or different types of reformations. According to Anderson and Montesano, they're classified into 3 types, with the first type being because of an axial loading force, wherein there is comminution of the occipital condyle. Type 2 with the occipital condyle fracture as occurring as a component of the basilar skull fracture, and the stability of this fracture is maintained by an intact alar ligament or tectorial membrane. Type 3 is an avulsion fracture of the medial aspect of the condyle. Okay, it occurs because of rotation or lateral bending or a combination of the two, and that there is a posterior displacement of an occiput in this kind of fracture. It is an unstable fracture, as I already mentioned. The medial part of the fracture will be displaced, and there is a posterior dislocation of the occiput also in such type of fractures. Next, moving on to atlas injuries, that is Jefferson's fracture, which occurs due to the axial loading force, as I already mentioned. So this causes the fracture of the anterior and the posterior arches of C1. So what do we see in this fracture is there are 4-part fractures because of the fractures occurring in the anterior as well as the posterior arches, leading to widening of the spinal canal, radial displacement of the fracture fragments, leading to mechanical and neurological instability. This is a stable type of fracture, whereas there is an atypical variant of Jefferson's fracture, which becomes unstable because of asymmetrical axial loading. So symmetrical axial loading leads to a stable kind. Asymmetrical axial loading leads to three-part fracture of the atlas, which becomes an unstable fracture, leading to a subluxation between C1 and C2 vertebral bodies. So what describes or what leads to the signs, what are the signs of instability is by the rule of Spence, which is because of the combined lateral displacement of the fragments on either sides of dents, or because of the avulsion of C1 tubercle, which is the site of attachment of the transverse ligament. So next, moving on to the fracture of odontoid process, as sir had already mentioned, it is because of the flexion and rarely because of hyperextension. There are several classifications, but I took Anderson and Alonso because it emphasizes on the stability, which again, it is difficult to see on parallel axial slices, hence reconstruction images have to be obtained. So type 1 is just a fracture wherein there is the dents, that is the base, at the base of the dents, they're usually obliquely oriented and is stable, just conservative treatment suffice. Coming to the type 2 kind of fractures. Now, in the type 1 fractures, we always need to differentiate them from os odontoideum, which is a common normal physiological variant. In os odontoideum, we will find that there is a wide zone of separation, round, smooth, and sclerotic margins. It is vertically oriented without interrupted lines, increased tubercle density, and angular orientation. Whereas in a fracture, we see that the zone of separation is very narrow with irregular margins, tilted odontoid orientation, interrupted posterior cervical spine, with the posterior shape being straight. Next, talking about type 2, which is highly unstable fracture, which is complicated by non-union. Hence, surgical fusion is always indicated in these type of fractures, wherein there is a fracture at the base of odontoid. This is an X-ray view showing the fracture at the base of odontoid, and the CT sections showing the similar fracture. Type 3, we see that the fracture line passes through the base of odontoid into the body of axis, and it is a relatively stable injury, and conservative treatment usually suffices this type of fracture. This shows a fracture line extending into the body. Next, moving on to the hangman's fracture, which occurs because of hyperextension and distraction, resulting in bilateral fractures through the pedicles of the axis. There is anterior dislocation of the body with tearing of the cord. So here we can see the fracture line parallel to the pedicles of axis. Again, they have been classified into three types, wherein the type 1 is mainly the fracture through the pedicle, type 2 extending to the intervertebral disc, and type 3 with the facet dislocation. So as I already mentioned, just a parallel fracture extending into the intervertebral disc and then into the facet joints. Next, moving on to fracture of the body of C2. Okay, so the fracture of C2 is usually rare and it's a stable extension teardrop type of injury. It may occasionally be complicated by trauma to vessels, hence MRI or CT angiography would be helpful to evaluate the status of vessels. So this shows the extension teardrop kind of fracture of C2 vertebral body. Now moving on to the next C3 to C7 level, that is mid and lower cervical spine. First, talking about the burst fractures, this mechanism is identical to Jefferson's fracture, which is because of axial loading injury, wherein the nucleus pulposus, which is normally contained within the disc, is driven through the fracture fragments, leading to the explosion of the body within, in fact, leading into a comminuted fracture. So typically, the posterior fragment will be posteriorly displaced, causing an injury to the spinal cord. If the posterior ligament is not disrupted, then it is a stable injury. So here we see the burst kind of fracture with mild posterior displacement of the fracture fragments. Next, teardrop fractures. These are most severe and most unstable injuries of the cervical spine. They characterize with the posterior displacement of the vertebra into the canal with the fracture of the posterior elements and disruption of the soft tissues. So in addition, the stress which is applied to the ALL causes it to rupture or avulse from the vertebral body, taking away a piece of the anterior body. This small triangular teardrop fragment is anteriorly and inferiorly displaced. It can often lead to anterior cervical cord syndrome, resulting in abrupt quadriplegia. However, the posterior column appears intact. in these type of fractures. As I already mentioned, there is a teardrop fragment which is dissociated along with the anterior longitudinal ligament. The upper parts of the vertebrae are posteriorly displaced, and there is a tear of the supraspinous, interspinous ligaments and strain to the posterior longitudinal ligament. So this is another CT view showing this type of fracture. Then talking the triangular fragment of the bone, as I already mentioned, can also be seen in extension type of injury, and the extension teardrop fracture appears to be relatively stable fracture which occurs in the upper cervical vertebrae, that is C1 or C2 kind of cervical vertebrae, mainly, predominantly. Next, about the Clay-Chauvel's fracture, which is an oblique fracture along the spinous process of C6-7, which occurs because of powerful flexion such as shoveling or a direct blow to the cervical spine can lead to it. It is a relatively stable fracture. Here we can see the fracture which occurs at the spinous process of C7. Next is a wedge compression fracture, which occurs again at the most commonly at the mid or lower cervical level, wherein there is a wedging of the anterior part of vertebral body and the posterior ligamental complex is just stable and mildly stretched. Here we can see the anterior wedging of the vertebral body. Then the most important entity, which are the facet joints. Now, there are unilateral and bilateral kind of facet joints, and there is perched facet joint. First, talking about unilateral locked facet joint, which occurs secondary to flexion and rotation forces, leading to tearing of the joint capsule of one facet, and the posterior ligamentous complex. It is a relatively stable injury, but we can see that there is subluxation of the upper vertebral body over the one which is below by approximately 0 to 30%. So that might lead to mild nerve root injury and Brown Sequard type of spinal cord injuries. So as I mentioned, here we can see unilateral facet joint, which is mildly dislocated and locked. And on axial views, we find the inverse hamburger sign. Whereas what is a bilateral or unilateral perched facet is, there is this type of vertebral subluxation mainly occurs because of flexion injury. There is just a disruption of the posterior ligamentous complex, and the superior inferior articular processes are just lie in opposition. They're not locked, they just lie in opposition. And the appearance of the facet joints is changed to a configuration wherein the laminar cortices are intersected at a point. So here, this is the mechanism of perching of the joint, wherein the superior articular process perches with the inferior articular process above. And there is a tearing of the posterior ligamentous complex, whereas the ALL has sprain but is not torn. The similar finding seen on X-ray view. Then bilateral locked facets occurs because of extreme flexion, and it is highly unstable injury which occurs because of the interlocking of the articular facets of the one above and below. This causes a lamina and spinous process of the adjacent vertebrae to spread apart and the vertebral bodies to sublux. And in chronicity, that later on what happens is the inferior articular process of the upper vertebrae locks in front of the superior articular process of the lower vertebrae, leading in complete anterior dislocation. So thereby we see that there is complete disruption of all the ligamentous complexes, and there is locking of the vertebrae with trauma to the cervical cord, thereby being highly unstable. So this is a similar X-ray view showing complete subluxation of the upper vertebral body as compared to the lower one. So in coming in a comprehension, that is totally flexion injuries can be hyperflexion sprain, a wedge compression fracture, unilateral or bilateral interfacetal dislocation. Extension injuries can be Handman's fracture, extension teardrop, or superimposed by spondylolysis. Next, moving on to the thoracolumbar spinal injuries. Again, CT plays an important role by the different views and deformations. Now, if we have to classify, as Sir had already previously mentioned, there are different classifications like AO, Dennis, and TLICS, and it depends on us which classifications we choose based on the clinical or the surgical entity that we need to proceed about it. So they're based on the mechanism of injury, they're divided into compression, burst, and distraction fractures. This slide I just put to indicate the importance of TLICS, wherein the morphology, integrity of posterior ligamentous complex, and the neurological status is taken into account. And based on the score, the surgery, if the surgery is necessary or not for the patient, will be decided. That is less than 4, no surgery, only conservative. 4, the surgeon takes a call. Above 4, surgery is definitely indicated. In the 10s3 model, as we already know, it is divided into 3 columns, with the ALL, anterior annulus, anterior 2/3 being one column, anterior column, middle column being the posterior 1/3 and posterior annulus, and the posterior column being the posterior elements as well as the ligaments. So here I'm mentioning the mechanism of injury, that is a compression, burst, seat belt, and fracture dislocation, and the columns of the spinal canal, that spinal cord, that's the anterior, middle, and posterior columns which are involved. In compression type, there is just compression of the anterior column. The middle column acts as a hinge, and the posterior column may just be distracted. In burst type of fracture, there is almost involvement of all the 3 columns, as we can see. Seat belt or chance type of fracture, there may be none involvement of anterior, mostly involvement of mid and posterior columns. In fracture dislocation, compression, distraction of all the 3 columns may be seen. So first talking about compression fractures, as I already mentioned, it is mainly because of anterior or lateral flexion, and it occurs due to failure of anterior column with the middle column acting as a hinge. And there may be a partial failure of the posterior column in this type of injuries. In lateral flexion injuries, compression may result in wedge type of deformity, and they will be identified as a reduction in the height of the anterior aspect of vertebral body. Next, talking about the burst fractures, as I already mentioned, there is failure of anterior middle column secondary to the axial compression forces. So here we see the vertical fracture of lamina together with increase in the interpeduncular distances, which helps in a diagnosis of burst fractures. So the fragments of these burst fracture may be retropulsed into the spinal canal, which results in neurological complications. Hence, CT will be essential in burst type of fractures. As we can see, the fracture fragments being posteriorly retropulsed. Next, coming to chance fracture, which is a type of distraction injury of the lumbar spine, also called a seat belt fracture, which occurs because of the horizontal splitting of the vertebra beginning from the spinous process or lamina and extending anteriorly through the pedicles and the vertebral body. They tend to be stable and occur because of the failure of posterior and middle columns. Now, again, these are divided into 1-level or 2-level type of fractures, with 1-level fracture mainly involving the bony column. And that is, if only the bony column is involved, it's a 1-level fracture. Only the ligamentous column is also 1-level. If there is a mixed involvement of the bony as well as the ligamentous column, then it becomes a 2-level fracture. Here we can see the horizontal splitting of the vertebral body. Next, the last type, that is a fracture dislocations, which occurs because of flexion, rotation, and distraction, which occur in anterior posterior or posterior anterior type of shearing injury. They are very unstable and they have severe neurological complications. They affect the posterior and middle columns, which are completely disrupted. So here we can see the fracture dislocations wherein there's a rotational type of force and there is a wedging of the vertebral body. In shearing type of forces, there can be 2 types of shear, that is a posterior anterior and anterior posterior shears. In posterior anterior, we see that there is a forward displacement of the vertebral body, whereas in anterior posterior, there is a posterior retropulsion of the vertebral body. In fracture dislocation of the flexion distraction type, it resembles that of the seat belt injuries involving the mid and the posterior columns. However, the annulus fibrosis is torn in this type of injury. Now, lastly, talking about the injury to the discovertebral junction, which is again a very frequent condition involving the discovertebral herniation of the intervertebral disc. The injury of the disc and the discovertebral junction can result from either acute or subclinical trauma, and depending upon the direction of herniation, a spectrum of injuries may be occurring. So this is a normal appearance of disc. Just a normal herniation of disc may occur. There may be an extrusion of the disc through the fracture fragment. There can be a corded or cephalad extension of the disc, or a posterior or posterior lateral extrusion of the disc, or the herniation of the disc. These are my references. I thank you all for this great opportunity. And the last slide, I would like to conclude by saying that remember to celebrate your milestones as you prepare for the road ahead. So this is a big milestone of our collaboration with the Society of Emirates and waiting for the long road ahead. Thank you.
Thank you, Shruti, for a very crisp, to the point and very informative lecture. And we as a MSK member, we are really proud of you. Okay, you have delivered an excellent lecture. So, Dr. Vijay, please introduce the next speaker. Thank you.
It's my pleasure to introduce the next speaker, Dr. Asad Shah. He is my colleague at SSMC Hospital. He was previously working at SKMC Hospital in Abu Dhabi. He trained in UK, Sheffield teaching program. Is junior to me from Sheffield training as well. A good friend and an excellent MSK radiologist. He did fellowship in UK from Stanmore. He has special interest in sports imaging, bone and soft tissue sarcomas, and image-guided intervention. And he's an excellent poet as well. If you, so over to Dr. Shah. He's going to talk about the role of MSK in spinal trauma.
Thank you, Dr. Vijay, and I thank the MSS team and organizers of this webinar to give me this opportunity of mutual learning and contributing. So let me just share my screen. Okay, and I'm gonna go. You guys can hear me okay, and the screen is, you can see the screen, yeah?
Yes, sir, please proceed.
Great. Okay. All right. So I'm going to talk for the next kind of 20-25 minutes about MRI. I mean, the title I was given is a bit poetic as well. I mean, it says Unveiling Hidden Realms. So let's see. So I'm going to build upon the talk by the previous speaker, Dr. Shruti. So, I mean, it's very heartening to see that it's a joint venture of two societies across borders, and that's what it's all about, that you have to collaborate and learn from each other's experience. Okay, right. So the outline of my talk is I'm gonna talk about, well, Dr. Shruti covered very nicely the basics of spinal trauma. Dr. Rashid kind of talked to us about the plain film. But when an MRI, I mean, my talk will be more focusing on the TLITS system and to assess the stability, what's the surgeon's perspective and what the imaging kind of can help in deciding the management of these fractures. We're going to talk about the discal and spinal canal pathology and also a bit about traumatic cord injury. Okay, let's see, sorry. So just briefly, I mean, just building on upon the last speaker's talk. So when we talk about spinal trauma, just basic kind of mechanism, I mean, we can have hyperflexion injuries, we can have hyperextension injuries, rotational injuries, and things like that. When we talk about the kind of the mildest form is your hyperflexion sprain, taking the cervical spine as an example. And it is basically, you can see a bit of widening of the facet joints, a bit of widening of the interspinous distance. But when there is a bit of subluxation, then you start getting worried about that this is something that is more kind of significant injury. Okay. And moving forward, if you get bifacetal dislocation, there's translation, then you're thinking about more ligaments disrupted. Okay. And obviously the risk of injury to the spinal cord increases, particularly in this teardrop kind of fracture. So this is the whole kind of grade of injuries that we can pick up on X-ray sometime, but mostly it's CT because most of these patients will have high energy trauma. And this day and age, we rely on polytrauma CT, and these injuries are picked up. And then the decision is from the spinal surgeon that if it's an unstable fracture or there is neurology, then obviously they're going to ask for MRI to decide the subsequent management. Just going to show you this table about these injuries. I mean, in the sprain, at the initial stage, you get just intraspinous widening, which means that you've got sprain or disruption of the supraspinatus or interspinous ligaments. But the main thing is when you start getting subluxation or widening of the facets or jumped up facets, you're thinking about the posterior ligament complex disruption, which is a very important determinant of the stability. And when you start getting posterior disc space widening, then the posterior longitudinal ligament is likely to be injured, all right? And then when you start subluxing it, when there is subluxation of one vertebral body over the other, then we are thinking about anterior longitudinal ligament disruption. So that's the whole kind of grade of injury starting from back to front. And as you go down, then the severity of the injury increases with likelihood of spinal cord injury. I mean, we have talked about flexion teardrop fracture, which is like this. It involves kind of more the kind of mid or lower cervical level. But when you go to C2, C3, then you can have an extension teardrop, which is a stable injury. So it's important to differentiate these ones, but occasionally it can be difficult. And we end up doing an MR to see whether this is just a avulsion fracture of the ALL or there is kind of disruption of the posterior longitudinal complex, making it a flexion teardrop fracture. The other is a hyperextension type fracture, in which if you see again, I mean, there is widening of the intervertebral space. When there is widening of the intervertebral space, then you think about there is an ALL injury. There might be kind of injury to the posterior longitudinal ligament. So it's important to have some familiarity with these fracture patterns. By the end of the day, if you see significant kind of fractures like that, patient has got significant mechanism, I think we end up doing an MRI. Coming to the stability, it's important to have a basic understanding of the concept of stability of these fractures. Obviously, I mean, conventionally we rely on the Dennis model of spinal columns, 3 columns. The anterior 2/3 of the vertebral body is an anterior column. The green bit in the middle is the pivotal kind of middle column with the posterior longitudinal ligament and the posterior 1/3 of the vertebral bodies, and then you've got the neurolarge and the interspinous ligaments and spinous process in the posterior column. So they say if 1 column is involved, we are okay. When 2 or more is involved, then obviously you're in trouble. But that's the basic understanding. But as we have moved over the last kind of 3 to 4 decades, obviously we have got availability of MR and all that. And then people have moved towards defining stability as depending on the degree of soft tissue injury, right? So in addition to the morphology and the extent and location of fracture lines, it is important that whether the soft tissues are intact or not, because that's gonna make that segment, that spinal segment, stable. And stability is the ability of that segment to prevent to avoid having progressive deformity and development of neurological injury. So that is the definition of spine stability by the surgeon. And an unstable spine will move under normal physiological loading into potentially deleterious deformation. So the surgeon or the clinician will always dread to do that. So whenever there is kind of suspicion of instability, then they tend to manage it operatively. So how do we decide that, right? So obviously there is this thoracolumbar injury classification score, which we're going to talk about. But the main kind of determinant of that is whether your posterior ligamentous complex is intact or not. And posterior ligamentous complex is made up of your PLL, but in addition, you've got the ligamentum flavum, the facet joint capsule, interspinous and supraspinous ligaments. And then they also talk about this tension band kind of concept, which you've got the tension like the anterior longitudinal ligament, PLL, the osseous kind of neural arch, and then these things, these are all tension bands. I mean, if you disrupt that, then you disrupt the integrity and the stability of the spinal segment. And that's where the AO spine kind of TL classification comes into play. I'm just going to briefly just take you through that. It's just important to have that as a perspective. Obviously, the severest injuries or displacement and dislocation, that is a C. So C injuries are always unstable. But when it comes to kind of hyperextension or chance kind of, these are also unstable if there is like an osseous kind of fragment with osseous kind of component in the posterior tension band in the neural arch and the posterior longitudinal complex, then it's a chance fracture. You can have osteoligamentous things. So this C and B fractures are all unstable, right? But when we come to the vertebral body fracture and see if there's a posterior wall involvement, then obviously it's going towards the burst fracture. If both end plates are there, then we call it a complete burst. If it's just one end plate, we can call it an incomplete burst, A3. Compression fracture, which are much more common, they're usually kind of stable. A1 fractures, if there is like one end plate, but you can have sometimes 2 end plate without involvement of the posterior wall. That's called a pincer or a split fracture. And obviously you've got transverse process fractures or spinous process fractures, then you can think about they're insignificant. But that's just the way the AO classification is. And some centers, they use it. So it's important to know which classification your spinal surgeon uses. But I think the most kind of important or the pivotal moment was when they came up in 2005 with this thoracolumbar injury classification severity score, TLEX or TESS, because it delves on the morphology of the fracture right? But also on the stability, which is determined by the posterior ligamentous complex integrity. And it's just important that if you see them intact, that's 0. But if you're not sure if they're lifted up or there's a bit of edema, some kind of disruption, not a complete tear, then it's 2, right? And then if you see them kind of lifted up, or there's definite kind of tear of these structures, then that's 3. And like Dr. Sruti said, if it's 4, if it's less than 4, we are good. These are stable injuries. You can manage them conservatively with a brace and things like that. But if it's 4, then obviously that's a surgeon's kind of call. But more than 4, that makes it a really unstable injury, and then people tend to go towards surgery. The other thing is, I mean, obviously, it relies on MRI to look at these ligamentous structures, but neurological as well. If you see, I mean, obviously there'll be clinical kind of input there as well, where the patient has got complete kind of quadriplegia, depending on the level and all, the complete cord injury, incomplete cord equina. But again, MRI also plays pivotal role in identifying the degree and the severity and the extent of spinal cord injury. So I think MRI has got a significant role in this kind of the central part of it. And we're going to see how it looks like. And I mean, coming to the MRI protocols, obviously, I mean, that's kind of variable, but the standard thing is you have to have you have to have 3 sagittals, T1, T2, and STIR. Some people use gradient echo to look for any kind of hemorrhage, particularly in the cord, but that's a personal choice. But I think you have to have fast spin echo, T1, T2, and then STIR. Axial wise, again, I mean, T1, T2 is more than enough. I think you can use STIR if you like that. Coronal, again, can be handy, but sometimes, I mean, that might be too much add to the length of the study. And obviously, if there is suspicion for a vascular injury, we can add MRA. But usually these patients, particularly in our institution, we tend to do a CT angiogram as part of their kind of trauma CT. Right. So just kind of going on the TLICS, I mean, when we talk about the morphology of the fracture, if it's a compression fracture, we give it 1 point, which is like a simple compression with wedge deformity. Burst is when the middle column is also involved and there is posterior superior kind of a displaced fragment. That gives it 2 points. When there's translation and rotation, that is 3. And the distraction that goes through and through with flexion at the front and distraction at the back, this comes as 4. So this is about the morphology, and we'll see how they look like. This is from literature. I mean, you can see that this is a compression fracture kind of involving the L1 vertebral body there. And on MR, obviously, you can see the T1 ISO intense signal there, the edema, and then you got that. And the other thing about MRI is MRI can pick up other fractures as well. Sometimes on CT, it's subtle, but obviously, you know that MRI is much more sensitive at picking up marrow edema. They say about 20% of the time you can find synchronous fractures as well. So probably it's important to use a STIR, like a whole spine sagittal STIR, just as a screening tool to see if there are any other fractures as well. Burst fracture, I mean, it's well kind of demonstrated on the CT with involvement of the posterior, the middle column and disruption of the posterior wall with that retropulsed kind of fragment. But obviously, this is associated with significant cord injury, depending on which level it is, right? And when you do an MR, then you can see, like in here, you got the burst fracture at L1, but there is an incidental fracture at L4 as well. And then you can see that this is the retropulsed fragment causing contusion of the conus there. So with burst fracture, they're potentially unstable fractures. The tendency is to get an MR and to assess for the degree of ligamentous disruption as well as the cord injury. In this case, I mean, you can see that this retropulsed fragment is usually attached to the PLL, and sometimes it's a bit difficult to see whether the PLL is intact or not. And obviously, these fractures need operative fixation. When it comes to translation or rotation, I mean, this is a gross example of fracture dislocation. Through the disc, you can see it's an intradiscal thing, and then the fracture that's a disc there. It goes through the ligamentum flavum, which looks there, and then you can see that it kind of involves all the intraspinous ligaments, and the supraspinous ligament is also elevated. The ALL there is a subligamentous hematoma there, and obviously there is a significant cord injury to this. But this is a gross example, right? Okay. But when we come to kind of more subtle example, I think whenever there is subluxation at the level, we have to look at the anterior and posterior longitudinal ligaments. Like this example from literature, you can see that there is lifting up of the PLL and also of the ALL. And a more gross example, you can see that there is a breakage here. So there is an ALL tear with more significant spondylolisthesis and obviously narrowing of the spinal canal with spinal cord injury. So traumatic listhesis always kind of look for ALL on MR to see whether there is a subligamentous hematoma and any disruption, because that will add 2 or 3 to the TLICS. Okay, moving on. I mean, this is another example. And the thing is, if you see there, that arrow is pointing to the ligamentum flavum injury. And there is edema in the interspinous ligaments and also the traumatic listhesis. And you can see there is discontinuity of the PLL with this subligamentous hematoma anteriorly. Another example, again, showing you the ligamentum flavum tear and this tear of the posterior longitudinal ligament. Right, chance fracture, we have seen nice examples in the last kind of lecture, but again, on MR, you can kind of see the whole extent of soft tissue injury. So look at this fragment there. When you see this fragment, that has to be pulled up by the PLL. This is where the PLL attaches, the PLL avulsion kind of fracture. But look at the splaying, or what we call the fanning up of the spinous process. This is through and through. This is a highly unstable injury. And in these cases, usually the fulcrum is anterior to the vertebral body, and you'll have duodenal injury or aortic injury with these, so seat belt injuries. So again, this is a highly unstable one associated with cord injury, and we need operative fixation. Chalk stick, Dr. Rashid showed very nice cases. I mean, you see it, okay? I mean, most of the time when we think about chalk stick, we think about ankylosing spondylitis things, but it can happen in people who have got florid dish as well, because it's a rigid spine, and then again, you can have through and through fracture. So have a low threshold to a CT, and then if there is kind of suspicious of neurology, then we end up doing an MRI. Okay, so I mean, is it always? I mean, is it only MRI that we could use to look at posterior longitudinal complex integrity? Probably yes, but sometimes we do see kind of things where there is a large fragment at the posterior superior thing, and when it gets rotated, that you know that the posterior longitudinal ligament is gone. So probably in this case, I mean, you can get away without doing an MR, but I think we live in a day and age where the spinal surgeons with this, they'll always want an MR just to probably prognosticate how much kind of cord injury is. So I think we can't avoid MRI, but with this kind of, when there's a rotated fragment, you can always be sure that this patient has got posterior ligamentous complex injury. Right, this is a nice paper, and initially this is from Kochi actually. I found it this week, and it was from 2016. But they looked at there was about 70 plus cases, but out of that, they looked at 31. And what they found out in 2016 was that there was kind of a high sensitivity for MRI in detecting injuries to the PLL and the spinal cord. But when it comes to ligamentum flavum and interspinous, the sensitivity drops down. I don't know whether that is true still or not, but obviously the point is that MRI is excellent at kind of assessing the degree of spinal cord injury, and also the posterior longitudinal ligament integrity, which are important things. When ligamentum flavum and things come, then obviously we need to be a bit more careful and probably more focused on that. But that just kind of gives you an idea that there is a variability, but these are the structures which we need to assess on MR. Coming to kind of, I mean, obviously we talked about ligamentous injury, but you can have true discal injury with acute trauma as well. I mean, in this case, you can see there's lifting up of the PLL with focal myelomalacia, focal cord injury with the disruption of the interspinous ligaments. But you can have, sometimes you can tear the annulus as well, and the disc material can extrude out. And particularly in cases of like bifacetal dislocation in the neck, you always have to do an MR to see if there is any disc fragment extruded or displaced into the canal, because that will affect the approach and the management by the spinal surgeon. Okay, I'm going to show you this case, just getting to the end of my talk. I mean, this is a T2 weighted sagittal and T1 sagittal image. And I think most of you can spot that on the T2 weighted, I mean, obviously this is your ligamentum flavum, but then there is something else here which doesn't look like ligamentum flavum. It's a more like an elliptical kind of curvilinear area at the back of the spinal canal epidural space. On T1, it looks a bit bright. When you look at the axials, which is very important, on T2, you can see there is this lentiform T2 hypointense signal. And on T1, It's a bit iso, but there's a bright rim of the dura there. So this is a posterior epidural hematoma, which are subtle because it's a small area you're looking for. Occasionally, you can look at the axial CT on soft tissue to find these, which are important because then this is potentially kind of adding to the degree of cord compression that needs to be evacuated to prevent any long-term disability. So look for epidural hematomas. Okay. The other one is like this one, in which, again, I mean, this is an unusual one. I just got it from literature just to add to this. If you see the spinal cord over here, it looks like there is a bit of focal indentation and it's kind of displaced forward. So there's nothing obvious at the back of it, but when you go to the axial, it's just kind of sticking to the front. There is no CSF anterior to the cord. This is quite a rare kind of injury in which basically there's a dural tear and there's a focal herniation of the cord outside the dura. This is, again, an unusual thing, but the point is that you need to look at the morphology of the spinal cord, look around it and in it as well. We tend to look inside the cord, but we tend to kind of not focus that much around it. So it's important to assess the anatomy in these areas. Okay, coming to the end, the traumatic cord injury, again, it is associated with particularly with unstable fractures, and obviously, I mean, the area we're looking for is on T2 or fluid-sensitive sequences to look for intramedullary high signal. Okay, and sometimes on stir you can see a linear thing, but I think it's important to go back to the axial T2 to confirm that it corresponds, and then you're confident to call it, right? Okay. And I mean, it's a spinal cord injury is the first description they say was about 2,500, like 4,000 years ago, basically, in this relic, the Edwin Smith papyrus from ancient Egypt. So it's a known kind of fact since probably antiquity, right? And the main thing is that we need to have a T2 weighted image. You can use stir, but I think T2 gives a better kind of confidence in assessing the degree of contusion as well as any intramedullary hemorrhage. So like in this case, if you see, this is from literature, but the extent is there. That's the extent is about 6 centimeter. But then if you look in the center part, there is T2 hypointense signal, which means there is hemorrhage. Okay, like focal contusion at the site of the fracture with lifting up of your posterior longitudinal ligament and an epidural hematoma. And again, probably some edema at the back as well. So it's important to use a T2 weighted sequence. And coming to the grading, I mean, I know, I mean, people who do more kind of neuroradiology, they might be more well-versed with it, but most of us who do trauma imaging and we end up reporting these, I think it's important to have an idea about this grading, Schaffer grading, which is easy because if it's normal, it's Schaffer 4. When it's just kind of less than a vertebral body, that comes as 3. So 3 and 4, they've got good prognosis. But when it starts going kind of more than kind of one vertebral body, then you are in trouble. So this is like 2 is kind of involved more than vertebral body. When you start seeing hemorrhage within it, that's type 1. So type 1 and type 2 have got the worst prognosis. This was, I think, probably it was devised in kind of early 90s or late 80s. And now people have moved towards this as well, which is called the basic score, which was devised in 2019 by this Brain and Spinal Injury Center. And the point is that, I mean, these are schematic diagrams there as well. When you start seeing, this is the gray matter. You see that H, we know this is the gray matter in the spinal cord. When the T2 hyperintense signal extends beyond the confines of that, i.e. C and more, then obviously that has got worse prognosis. But this is something just to keep in mind. I mean, if you want to use it, you can read that the reference is there. But that's an important aspect that you need to assess the degree of gray matter involvement on axial T2 weighted images. So that's about it. I mean, to conclude, I think, I mean, MRI is essential for assessment of ligamentous and cord injuries. And I think people are moving towards more kind of liberal use of MRI. I mean, in our institution, most of the fractures, whether it's a stable compression fracture or unstable burst or distraction injuries, I'm going to do MR just for screening, because probably we see so many injuries. They just want to be sure that the ligamentous complex is intact, and then kind of decide on the basis of that whether we manage them conservatively or operatively. I mean, you can argue if the MDCT on trauma scan shows you a burst fracture with burst fragments and all that, then they might, I mean, get away with it. But I think whenever you get unstable fracture, always the catch is that, is there a spinal cord injury? Is there epidural hematoma? Things like that. So I think we can't get, I think most of the time when there is a fracture, a significant fracture, then we end up doing an MRI. And obviously it is great, it has got great capability of assessing the degree and severity of ligamentous injury as well as cord injury, which will help prognosticate the outcome of the patient. So I thank you all for your attention. That's me, and I've worked in Sheffield, like Dr. Vijay said, and then that's a place where I did fellowship with Dr. Safuddin, who passed away last year. And that's it. Any questions? I'm more than happy to answer. Thank you.
Thank you, Dr. Asad. It was an excellent overview of role of MRI. I think we'll take the questions at the end because we're running a bit behind schedule. So I will ask Dr. D.K. Singh to introduce our next speaker, Dr. Anandita Sinha.
Yeah, welcome, Professor Anita. Okay, she is a faculty in one of the India's largest institute. Okay, and she is the program director of musculoskeletal radiology fellowship in Postgraduate Institute Medical Research, Chandigarh, India. Many publications, as you can say, 69, and chapters in the book 16. And she's a well-known personality in MSK intervention in our country. So, Dr. Anita, over to you.
Thank you very much for the kind introduction. Dr. Mahesh is the program director. I'm also one of the faculties. I'll just get a minimal correction. I'll just share my screen and hopefully this is visible. So, intervention strategies in spinal trauma, I'll give a brief overview, and it is very elegantly and poetically entitled Paving the Path to Recovery. So, the overview will be whether what are the indications for minimally invasive interventions. And there's a difference in terminology between what we call minimally invasive and what the surgeons call minimally invasive. So, we'll just briefly discuss a little bit about that and what types of vertebral trauma can be treated by us. And actually, what is minimally invasive spinal surgery, or MIS, a step by step of the surgical part versus our part, which is mostly vertebral augmentation. And then we'll go a little bit into spinal injections. So, what are the advantages of minimally invasive techniques? We know there's less blood loss, less muscle damage, which is very important for early recovery. Not only that, even the surgical site infections for the open or even minimally invasive versus R, which is actually should be termed microscopically invasive or almost non-invasive, is 0.12. Largest series says 1.5% versus 10%. There is less pain medication required, and better cosmetic outcomes, faster recovery times as well. So, see, this is one of the surgical incisions for the minimally invasive surgeries done by the surgeons. This is not the open surgery. So, there's a difference in terminology. As you can see, they're giving sutures. We don't give any sutures. And this is the faculty who does. So, we'll be discussing a little bit of that. And then indications for minimally invasive include a lot of things, also vertebral fractures. And we are already the classification has been discussed so elegantly by the previous speakers. But what I'd like to harp on is that we generally do the interventions only for the compression fractures, the A1, the A2, and the A3 and A4, which are the complete or incomplete burst fractures. And what are the techniques and strategies? So, MIS, or minimally invasive spinal surgery, which relies on a principle of decompression and stabilization and also deformity correction. There are spinal fusions, spinal fixations also done by surgeons. We are doing the vertebroplasty, kyphoplasty parts, and there are third generation vertebral augmentation devices also used. So, if there is the reason to do spinal fusion, it'll be off our hands. We'll say we can't do it, and it'll be over to the surgeon. But studies have shown that spinal fusion is actually not necessary. So the rest of it is approachable by both us and the surgeons. So even for single level burst fractures, it is possible to do both a surgical approach with minimally invasive surgery or a vertebral augmentation approach. So just a brief overview. So the initial part of pedicle access remains the same, whether we are doing a minimally invasive surgery or a vertebral augmentation. And you insert a K wire after you approach it through the pedicles, the vertebra through the pedicles, and then you dilate it through a serial dilatation, which is something that we don't do. This is the part where the surgery is taking over, something that we are not doing to increase the space within the muscles by serial dilatations. Then there's tamping with the oil. We do this also for the kyphoplasty, but we don't do the serial dilatation. And this is the picture of the tamping of the oil of a minimally invasive surgery being done. But here the procedure gets more complicated. You need a screw insertion with an inserter, and there's a lot of technical expertise required for doing this, for not only inserting the screws, but for inserting and orienting the screws so that the rod is oriented properly. So you need to have calipers to measure these screws, measure the rod insertion. So this is just the screw insertion container of the surgeons. You can realize there are many more containers that are available. So you can realize the complexity of this minimally invasive surgical procedure. So now the rod insertion has another rod manipulation pack, which is this pack. So this is the second pack. And you see that now they're inserting the rods in the separate vertebra. Another complex procedure included for the final rod insertion, orientation, and distraction compression. But one advantage of this procedure is also you can insert cement, and there are cannulated screws through which cement can be inserted through these pedicles. But the problem, as you can see, is that the procedure is very complex, and why this has not been widely adopted by the surgeons is because the teaching curve or the learning curve is very, very long. And even the articles say at least 30 guided procedures have to be done before they gain any sort of mastery over the procedure. So the question is, should we do vertebral augmentation at all? Is there any evidence? So whenever you start doing it, there are naysayers who say that is already proven by studies that it has no benefit. This was the Virtus 4 trial. For those who know, we said that there is no evidence of any advantage of any vertebroplasty or kyphoplasty. But the problem is they did not evaluate the intervention in acute fractures. Whereas there are now studies, even meta-analysis, which have proven that not only for acute osteoporotic fractures, but even this talk of traumatic fractures, vertebroplasty or kyphoplasty or the third generation devices have a lot of positive role and a positive outcome. But the caveat is the vertebral fill technique has to be proper, and if it is done within 6 weeks of the fracture, it has a proper outcome. So there's now a meta-analysis of 2 million patients in osteoporotic vertebral compression fractures, and it shows that even at 10 years, the people who underwent, or the patients who underwent augmentation, were 22% less likely to die than those who did not go any surgical treatment for the compression fractures osteoporotic. So we have swung the pendulum the other way from 2018 Cochrane review, which did not support vertebroplasty, to a 2 million meta-analysis, which shows that there is decreased mortality rate for people undergoing vertebroplasty or balloon kyphoplasty, but most of this is for osteoporotic fractures. So now is there evidence for acute traumatic fractures? So there is a study, again a systemic review now, of 51 studies, where 12 studies were about kyphoplasty and or armed kyphoplasty or the third generation devices, which shows that there is significant statistical improvement in both the clinical as well as the functional and as well as the radiological outcomes, with decreased kyphosis and increased vertebral height, along with the pain management, along with the decreased hospital stay, along with the increased or rapid return to work. So briefly about the procedure, how do you go about it? You have to operate the patient. You need to evaluate the patient yourself, and not only the patient, also evaluate the imaging, see if there's an actual decrease in vertebral height of more than 4 mm, evaluate the prior x-rays, the CT, MRI for the spinal canal with the beautiful talks given previously, for the posterior wall, the posterior elements, see that the INR is less than 1.5, the platelet count is 1,000 and above, 1 lakh or above. Aspirin can be continued. Other low molecular heparin has to be stopped pre-procedure, but clopidogrel needs to be stopped at least 5 days before the procedure. Again, antibiotic prophylaxis is to be started pre-procedure according to the textbooks or according to guidelines. We generally don't give antibiotics over here. Only if there is any indication we give antibiotics. If there is, but till now there has not been any antibiotic given pre-procedure by us. So the red flags are if you see the cortical disruption in the posterior aspect, or the posterior cortex has been retropulsed, or there is spinal cord compression, we should not do the procedure or desist from doing the procedure. Now, should we do vertebroplasty or kyphoplasty? Studies have shown that they have same relief or the same mobility with similar complication rates. But kyphoplasty is generally preferable because you can you create a cavity where you insert the cement. You can insert high viscosity cement, inject, and with less chance of cement leakage, which is a morbid outcome if you do have it. And the kyphotic angle is generally a bit better. So what is the hardware that you need? You need a C-arm. You need either a biplane. We have a biplane, but we don't use it because it's always busy by the neuro interventionist. So we use a routine single arm, and because you need to rapidly do AP and lateral. But what you need is a hammer, which is not given with the kit. And this hammer we have ourselves. We don't borrow it from the orthopedicians. We have various sized hammers. And you need iodinated contrast, which is also does not come with the vertebroplasty or the kyphoplasty kit. So the vertebroplasty kit generally comes with an 11 to 13 gauge vertebral biopsy needle, and you then have another introducer needle. So this is one vertebroplasty needle, another bigger introducer needle is given, and you have the cement, which is the powder and liquid mixture, and you have balloons which you can insert either unipedicular or bipedicular. So what you need to do is first, when you see the patient has to lie prone. We give a trial to the patient before putting the patient on the table when we are evaluating the patient initially, because many patients may not be able to lie prone, and you need to take the anesthetist into confidence. When you see the prone view, when you're doing the procedure, the end plates have to be parallel and not oblique, so that both end plates, superior end plates, are projecting on top of each other, and the pedicles are seen well and projecting within the vertebral body, because if they're oblique or outside, you will potentially harm structures, vital structures anywhere. So this is just how we go about the procedure. This is the initial vertebral biopsy needle, and through this, once you are into the pedicle, we insert the K wire through this, then take out this initial vertebral biopsy needle out, and through the K wire you insert a wider gauge, 8 gauge, this vertebral needle, so that cement goes in easily. And before this is done, also I'll be showing in the sequential images that you do a bit of reaming also of the vertebral body. So once this is in, before you do this, you have to widen the incision a little bit, because this does not go in easily, and you have to hammer this in, even in osteoporotic vertebrae. This has to be inserted. Now this is the bone filler device. So these are the bone filler devices where we load the cement in, and then we inject the cement in through this needle into the vertebra. So we generally use fluoroscopy guidance, but over here, when we have to do a procedure within the L5 vertebral body, then you have to use a hammer. So hammering is done properly in the CT guidance, because L5 vertebral body pedicles are oblique. And CT, sometimes you can miss the pedicles or the proper view of the pedicles if you do it on fluoroscopy. So for L5 vertebral body, we prefer CT guidance. But this is a case of a compression collapse of multiple level compression, actually, of L1 and L3. So the pedicle has been approached through a lateral approach, and once the pedicle is there, the needle is there in the pedicle. You see here on the lateral, by multiple times switching AP and lateral, that this has already approached the pedicle. The medial margin of the pedicle, the needle should not breach till it has approached the posterior margin, because otherwise you will be potentially damaging the spinal cord. Now, once this is inside, then we insert the K wire, and when the K wire is inserted, here you see the K wire has been inserted. The K wire is inserted, this initial vertebral needle is taken out. You can take a biopsy also if required, but generally the biopsy has been done previously. If at all it's a case of suspected pathological fracture for trauma or acute traumatic condition, that condition does not arise. Then you introduce the bigger, that 8 gauge vertebral needle inside. We are hammering it in. After that, you generally ream within up to 3 millimeter of the cortex, so that you create a cavity with the reamer. So this is the cavity being created, and when you're approaching the vertebra or the pedicle, your vertebral needle approach angulation has to be according to which vertebra is with the vertebral angulation, or the which end plate is actually more collapsed. So here you see we have angulated the needle from superior to inferior direction, so that the reaming or the balloon also dilates the superior cortex more. If both the cortexes are equally involved, then the balloon can go in more in a horizontal direction. So once this is done, the reaming is done. We generally tamp because it creates sharp edges and the balloon potentially can burst. So once this reaming is done, we tamp it with the tamps, which is actually the balloon or the bone filler devices only, and we are tamping it so that the sharp edges are removed from here. And once this is approached, we are doing a bipedicular, we approach the second pedicle also. And once the second pedicle is approached, we again then insert the tamps, the bone filler devices. Or here we are doing a bipedicular or the another vertebra, the L3 vertebra, but we didn't have so many introducers, so we are doing a unipedicular for the L3. Same procedure done for the L3. Then for inserting the balloon, here you can see that this balloon is being inserted, and this is the tip, the radiopaque markers for the balloon. And you can see that we are going to dilate the balloon serially by loading the contrast filled contrast into the balloon, and the superior cortex hopefully will be elevated a bit. So the this is the video running. So the balloon is gradually inflating, and this is the waist of the balloon which happens. And once the waist goes, you know that the balloon has been completely inflated. So the balloon positioning here is okay. It is more near the collapsed superior or the compressed superior end plate, and you see the waist gradually vanishing over here. So you know that the complete balloon dilatation has happened. And sometimes the elevation is very subtle, and we do the pre and post measurements. So cement preparation is another important part. So cement preparation and loading has to be done in a very time bound manner, because then the cement will get solidified within the bone filler device, and it will be very difficult to take out. So once this is done, we mix and then we wait for the consistency of the cement to become toothpaste like. So once it is toothpaste like, how do you know that it's toothpaste like? Once you load the cement into the bone filler devices, the toothpaste should hang, or the toothpaste like consistency cement should hang and not drop down. That means that the cement is ready for injecting. So once it is ready for, so this is now dropping down, so that means we have to wait a little bit more, and it is temperature sensitive. So in warmer temperatures it takes place faster, and in colder temperatures this cement solidifies at a slower rate. So once this is ready, we start injecting, and you can see here that we have injected cement, but it is also a good idea when you are injecting or before you're injecting cement, what we sometimes do is we do a contrast vertebroplasty. So here you see we have done a contrast vertebroplasty, and you can see this rapid filling of the vertebral vein on the anterior side. If this is so, there is a chance that cement might leak out through this into the vertebral veins. And if we find this rapid contrast leakage anteriorly, then we change the position of the vertebral introducer needle a little bit so that we don't get any contrast leakage. And after that, we fill the vertebral body with cement till the anterior 1/3 of the vertebra, till you get proper vertebral cement filling, which is very important and necessary. And also interdigitation of the cement is necessary. So this is the end result, and you can see quite good interdigitation in the bipedicular approach, but we didn't have a proper second introducer, so we did just an unipedicular, and there is incomplete filling of the L3 vertebra, but the patient did have pain relief. So what are the complications that can arise? The complications that can arise are the dreaded complication of cement leak. So this is, we haven't had cement leak till now. And you can have embolization, cement leak into the vertebral canal causing paraplegia. You can have pulmonary embolism if you have that rapid vertebral filling through the cement, with the cement going into the pulmonary veins, causing a pulmonary embolus. This is a complication we have had. This is a cement tail, and cement tail happens if you are delaying the taking out of the bone filler device a little bit, so that the cement solidifies within the vertebral body. And here it is solidified into the pedicle, but it has not still leaked out. You can sometimes have transient worsening of pain, and then you investigate thinking that either there's cement leakage or a pedicle breakage or some compression. But we have had one patient of this with gross transient worsening of pain for the first 7 days, and it automatically subsided on its own. So again, we should evaluate the cause of worsening of pain, but sometimes it can occur. Either immediately or more so delayed adjacent vertebral body fracture is known in vertebral augmentations, and infections can also occur. Pneumothorax and rib fracture can occur if you're doing thoracic. Now, the relative contraindications are very severe compression or vertebral plana. Obviously, you don't do it in bleeding disorders or infection, or if there is a posterior element or cord compression. Also, do not do it in asymptomatic patients, and if the patient cannot lie down prone. The relative contraindication of severe compression is that it depends upon the expertise. Here we have done it in a patient who almost had vertebra plana with a compression fracture, but the patient was in such severe pain that we did it. And you can see that the other important thing that you should look for over here is the pedicle width, and we really didn't have too much manipulation power over here because the pedicle was very narrow. So we did bipedicular vertebroplasty, the kyphoplasty till the posterior cortex, not till the anterior one third. But the patient who had come down to us in a trolley went away walking and was very happy. So pain relief was excellent. The disadvantage of kyphoplasty is sometimes when you remove the balloon deflation, the vertebral height may not recover completely, and the recovery of the vertebral body height may only be temporary. And often there be a total or partial body collapse once the balloon is deflated. So to overcome these complications, there are third generation vertebral augmentation systems. There are vertebral body stenting, OsteoFix, and the new kid on the device, that is spine jack, which many people are excited about. One disclaimer: this is the spine jack, this is the OsteoFix, this is the vertebral body stenting. I have not had personal experience with either of these. I've just done kyphoplasties and vertebroplasties. So any of the speakers or delegates who have experience with this, but I'll be showing this. This is a vertebral body stenting, and all of them have been used in both osteoporotic as well as traumatic fractures. The spine jack, there's now lots of literature. So the approach for vertebral body stenting is the same. The same balloon is used. The recovery of height and reduction of fracture is the same. And here you can use more viscous cement, so chance of cement leakage is even less. And because you're putting a stent in, the balloon can be removed without the risk of losing the vertebral body height. So this is an interesting complication I came across in literature, where you see, because there is space created, or maybe this patient had too much of a collapse, the stent which should be end on this here, like you can see through the stent here, the other stent has flipped. So once the stent is flipped over or tipped over, you cannot inject cement through this tipped over stent. So this is one of the complications, but the contraindications are again that if it is a type of B or C injuries, you generally cannot do a vertebroplasty, the vertebral body stenting. And in B and C injuries, you anyway cannot do a kyphoplasty or vertebroplasty. So the spine jack, again, it has been it has been used in both traumatic and osteoporotic fractures. It causes a very anatomical restoration of the vertebral heights on kyphosis angle reduction with a lot of decreased post-operative pain. And so it comes in 3 sizes. So you can see over here in this video I've taken from YouTube that it causes this magnificent increase in height or restoration of the vertebral body height. And you can fill in cement, and the cement has to interdigitate again in this also for proper restoration and proper anatomical restoration as well. And this is an article picture from the same study of where they have compared spine jack with posterior arthrodesis and found that there is actually no post-operative pain difference. In fact, discharge time is less, and there's no adjacent vertebral body fractures with this system. And they required earlier discharge with fewer hours of nursing care with better radiological outcomes with spine jack. So coming to the end, is there a role for PRPP? It does promote bone union in spinal fusion surgeries. It is used in spinal cord injury also. There is anecdotal evidence that it causes spinal ligament early healing. There are case reports of that. There is quite a good evidence that it actually helps in deep surgical site infections after open or minimally invasive spinal surgeries. In patients who have undergone 2 or more surgeries to decrease the infection or debridement, PRPP has actually been injected, and it has caused complete wound healing with no recurrence. And of course, in many patients where there are pressure ulcers, there has been where patients are non-ambulatory, this has actually healed the pressure ulcers. So I have not gone into details about vertebral injections because most of these epidural injections are not done by us. And but we generally do the erector spinae blocks or the radicular nerve blocks while doing the kyphoplasties as an adjunct measure to decrease the anesthetic requirement. We generally do these vertebroplasties or kyphoplasties under local, and at the time of hammering, when the patient is unable to bear the pain, the anesthetic gives a bit of fentanyl or some mild sedation. But we need the patient to be awake so that he can give any response to us about if any tingling or numbness or any discomfort that he's feeling. So what is the take-home message? There is evidence that early intervention in trauma is robust. There are lots of meta-analysis now, and but planning and fracture evaluation for proper case selection is important. We should take time out for proper image evaluation with both the X-ray. CT is a must, even if the patient has MRI, because you may see some retropulse bone fragment which you're not able to appreciate on MRI. That would be a contraindication. Adequate hardware and hardware planning is needed, because if you do not have that hardware at the time of the intervention, you may land in trouble. And the new generation devices may be game changers. Thank you very much. This is the end of my talk.
Thank you, Professor Anita ma'am, for illustrating and delineating the every fineness of the kyphoplasty. And thank you so much, ma'am. Thank you. Over to Dr. Vijay. Vijay sir for next speaker.
Hi, come back. Our next speaker is Dr. Asaf Fargal. He's a consultant interventional and MSK radiologist at Tawam Hospital at Alain, which is another city in Abu Dhabi. He's a European Board Interventional Certified. He's done a vascular fellowship and interventional radiology fellowship at McGill University. And he did his subspecialty training in UK. He has extensive experience as a consultant radiologist, both in UAE and UK hospitals. And he was my previous colleague at SSMC Hospital as well. And he is an excellent MSK and interventional radiologist. He does a lot of spinal work. That's why I've asked him to do this talk, which is hopefully it will be a very useful talk for a lot of us. So to talk first.
Thank you, Dr. Vijay. Good morning, everyone. Let me share my slides. Can you see my screen now?
Yes, sir. Please proceed.
Okay. I have been giving the talk of talking about the spinal metal work. And as you know, we are radiologists. Metal work is something done by the surgeons, and sometimes it's quite confusing for all of us. What are the devices that they use? And every day there's a new thing that's coming in the market, and for us as a radiologist, sometimes this can be a little bit confusing. So I've just selected few topics to talk about in the next
Sir,
20
sorry to
minutes or
interrupt
so.
you. Your voice is bit low, sir. Can you please hold your mic closer?
Okay, can you hear me now?
A bit better.
Yeah, okay. So in the next 20 minutes or so, I'm just going to cover a few topics. So I'm going to talk about the types of cervical and lumbar fusion. I'm going to try to cover imaging of postoperative spine. We're going to talk about arthrodesis and pseudoarthrosis. And then we talk briefly about imaging of the spinal surgery complications. So let's start with a spinal fusion in the cervical spine. The indication of cervical fusion in the cervical spine usually either discogenic pain or nerve root compression, or either a spinal cord compression, trauma, or following tumor resection. And it can be done anteriorly or posteriorly. So the anterior approach involves removal of the disc with corpectomy and fusion. In the posterior approach, typically it's either done by laminectomy or laminoplasty, and again with fusion. And then there is a combined technique with which anterior and posterior approaches can be done, and they call it the 360-degree. So this is an example of the anterior cervical fusion, and you can see here it's a one-level fusion. Let me see if I can get my pen. Can you see my my laser pen? Yeah. Can you see that? So in the anterior approach, it's simple screws in the vertebral bodies, and then plate is inserted inside, and then the disc is removed. and then they hope that this area will fuse as the time goes on. But as you remove the disc, you create a cavity in that space. So there is an interbody fusion plugs or cervical cages that the surgeons insert to fill that gap. And they are made of different materials. The commonest one is the stainless steel or the titanium, but there are newer generation coming in the market with a more sort of synthetic material, like the one here in below. And it's filled with cement, and that cement can be, bone graft, and that graft can be an allograft or autologous graft. And usually it's inserted more anteriorly in the disc space to maintain the cervical lordosis. So this is an example of a multi-level fusion, and you can see the screws with the plate, and then in between, these are the cervical cages. Another type of fusion, which can be done with multi-level corpectomies. So this is a corpectomy with a fibular strut graft and titanium mesh cage. So this one is the fibular strut graft. So they take part of the fibula and then they insert it, and then they fill the lumen with bone graft just to compensate for the lost height of the removed vertebra. And then again, they put screws and metal work. And the second type is the mesh cage. It's a metallic construct which can be adjusted according to the height, and again filled with a bone graft in the middle. The posterior cervical fusion is usually done with either laminectomy and fusion. So in the laminectomy, the whole posterior lamina is removed, and then fusion is done posteriorly by screws and rods. Or laminoplasty, where they remove part of the lamina and then they do osteotomy on the other side. And then this can be either constructed by a metallic plate posteriorly. If laminectomy is done alone without fusion, it tends to be very highly unstable, and the rate of failure is very high. So this is pretty much not done nowadays anymore. So what about in the lumbar region? So lumbar spinal fusion, again, the indication can be for stenosis, coda equina compression, spondylolisthesis, discogenic pain, nerve root compression. And again, there are multiple approaches. So the anterior approach, which is the, again, similar to the one that they use in the cervical spine, or posterior approach, or the PLEF, the transforaminal approach, or they call the extreme lateral or direct lateral approach. Just a small word about another device which is used for especially the cervical spine. It's called the low profile device that function as both a spacer and anterior cervical plate. It attaches with the boundaries of the opposing end plates, which requires no additional plates. So you put this device in and you screw it, and that's it. And it doesn't protrude anteriorly beyond the end plate, so it doesn't cause compression of the soft tissue of the neck. And the fusion rate is very similar to the standard anterior approach. Usually within 2 years, we achieve about 90 to 95% of fusion. Another device, which is called a disc replacement. So it's an alternative to cervical or lumbar fusion, where the disc is removed and this device is inserted, which it's replacing the disc. Its advantage, that has a better maintaining the disc height, and also maintaining the range of movement, so you don't lose the movement, you don't fuse the spine anymore. And then as a result, you tend to decrease the risk of the adjacent segmental degenerative changes as a result of the fusion. So this is an example of the total disc replacement in the cervical spine here, and this here in the lumbar spine.
Sir, sorry to interrupt you. Your voice is still very feeble, sir.
I don't know what to do to make it higher.
Sir, is it maximum sound in your laptop? Is it maximum?
Yeah, let me check. It is max. Can you hear me now?
Better, sir.
Probably. Okay. Better now? Okay. So in the next, we're going to talk about arthrodesis versus pseudoarthrosis. So what is arthrodesis? This is the aim of the fusion. Usually the spine is fused either anteriorly or posteriorly to achieve an arthrodesis or complete bony fusion. And that will support the spine. And as a result, this would avoid the abnormal motion that happens at that level and causes the symptoms. Now, when this fails, it ends up into a pseudoarthrosis or the non-union. And that can be incomplete bone union and that will lead obviously to the motion at the site of surgery. And this can obviously cause more symptoms or it can cause even impingement on the neural structures adjacently. And they can present again with pain, instability, or neurological deficit. So arthrodesis may require several months to years to be achieved. And usually it takes about 6 to 12 months to achieve arthrodesis. There are multiple factors to contribute to a good or successful arthrodesis. Some of it is related to the bone graft substrate, and some of it is related to the quality of the immobilization at the level of the operative level. There is also some other factors that predispose to pseudoarthrosis, like excessive motion, the trauma, smoking, diabetes, malnutrition, steroid use, and osteoporosis. So poor bone quality to start with can lead to arthrodesis, to pseudoarthrosis, sorry. So what is the success rate in the fusion in the cervical region? So if you're doing a single level, usually the success rate is about 95 to 100%. The more levels you do, the less success. So 2 levels end up into 93 to 95, and in 3 levels, the rate goes down. Plating increase the success rate. Sorry, this should be fusion rate, not the effusion rate. And fusion rate of the titanium mesh cage and the fibular strut grafts are very similar, so from 90 to 100%. So what about in the lumbar region? Lumbar region, again, it's a very highly successful procedure, so they can achieve up to 90%. And that rate of pseudoarthrosis varies significantly when you add more levels. So higher, the longer the construct, the more likely the stress on the construct, and as a result, the failure rate can become higher. So when do we do imaging? What's the aim of doing imaging in post-operative imaging? So post-operative imaging is usually done mainly for 3 reasons. The first reason is to assess the immediate complication rate and also to assess the integrity of the construct. And then later on to allow for hardware assessment for recurrence of new symptoms. It's helpful to assess the fusion status, particularly in the settings of clinical symptoms suggesting pseudoarthrosis. So if there's any change in the symptoms, this is the time you need to start doing some imaging. However, just bear in mind that pseudoarthrosis usually seen within 6 to 9 months. So any time before that, you shouldn't really call non-union pseudoarthrosis, because it's very rarely, it's still in the process of healing. And symptomatic pseudoarthrosis usually seen within, as I said, 6 to 9 months. X-rays are not very helpful, although sometimes it can show you evident screw fractures in the flexion and extension views. However, the CT and MRI is much better in giving you the higher resolution to detect these subtle changes. So on imaging, what are the signs of successful fusion? If you see a continuity of bone trabeculae between the construct, between the fused segments, that's a sign of successful fusion. The fusion should have a minimal height loss at the disk space, and the movement in the flexion and extension view should be less than 3% of movement. And then at the end, when the fusion is complete, you should see a sclerotic line between the graft and the vertebral bone with a sign of sort of bone remodeling. What are the signs of failed fusion? So on the other hand, you can see in a failed construct, you see discontinuity in the bone density. You see more motion at the surgical level in the flexion and extension view. And if there is a lot of hardware lucency, or if there is subsidence. So we're going to see some examples of these. So this is an example of a successful fusion in the cervical spine. You can see the, let me put my laser on. You can see the fused segments here at these 3 levels with mature bone bridging. And then on the MRI, you can see the marrow signal bridging across. So that's a successful fusion. Again, this is in the lumbar spine. So bone bridging in the disc spacer or the cage. And reasonable fusion. It doesn't have to be there through the entire space, but just enough to see bone bridging between the 2 vertebrae. And again, in the lumbar spine in CT, you can see well, a little bit of difficulty, some bridging here between the bones. And then in the MRI, you can see the continuity of bone marrow signal through the fused segments. What about pseudoarthrosis? So this patient had a central canal narrowing at C3-4, for which he had anterior decompression, and the cage was inserted. And then a year later, you can see there is still a line between the C3 and C4. It hasn't been fused. So this is a sign of pseudoarthrosis. Another example, anterior fusion with failure. So the screw went forward and there's a subsidence of the disc spacer anteriorly, and you can see it's moved forward here. So this is a failed surgery. Again, in the lumbar spine, posterior subsidence of the disc spacer posteriorly, which is compromising now the central canal. Pseudoarthrosis in this case happened in the last segment. So as you can see here, there's a bit of loosening in the last screw here, and failure to fuse the L4-5 level. You can see the line here. This has not fused. This is fused between these 2 levels. But then this one is still, there's a loosened line here. So this is pseudoarthrosis and loosening of the lower screws. So what are the complications of the spinal surgery? The most serious complications of the spinal surgery are rare. They are less than 1%, but they can be catastrophic. So death, cardiac arrest, pulmonary embolism, cerebrovascular accident. We had a case recently, actually last week. The patient was transferred to us from another facility with a trauma to the common iliac artery, for which they had to put an emergency balloon inside, and the patient transferred for more sort of stenting of the vessel. So it can be catastrophic. Imaging is very important to identify the complication related to spine and instrumental or injury of the soft tissue, especially the vascular structures. And it may need, you may need to see the metal artifact, you may need to use the metal artifact reduction techniques to better visualize the soft tissues and the central canal. So these are the common complications. So hardware failure, malposition, compression fractures, particular disease, infection, adjacent level disease, disc degenerative disease, cervical kyphosis, and failed back surgery. These are also other spinal post-spinal surgery complications, that we're going to talk about some of them as well. So the most common complication is loosening, which can, as we said, usually happen as a delayed complication after 6 months to a year. You can see here in that fusion, there's a loosening of that space around that top screw. And in the coronal image, you can see a lot of loosening around this screw here, with failure of the fusion at that level here. This is an example of a hardware and graft failure with pseudoarthrosis and a fracture of the top screw. You can see the fractured screw, failure of fusion here, although it's fused down here, but still fractured here. And on the axial view, you can see the fractured screws on the top here. Malpositioning of the screws is an important finding that has to be reported. So you need to review the axial images very carefully and make sure that all the screws are in the correct positions. So this screw, for example, is not in the pedicle. It's traversing the canal in the lateral recess. It's an important finding to report. Fractures at the end of the construct can be missed, and you have to really look at the end very carefully, make sure that you, especially at the end of the construct where a lot of movement is happening. So if you can imagine, everything is fixed in this area, and the lot of the stresses are happening at this area. So just have a look at the last level, make sure that you're not missing a fracture like this one here. Metallosis is another complication, especially with the total disc replacement. As you can see here in this example, there's a lot of osteolysis due to the cellular response to the particulate, especially the metal, where it's causing erosion and osteolysis here. Infection, it can be acute or delayed. Acute usually within 30 days versus delayed, which is usually less than 10 to 12 months. The incidence is about 2 to 6%. And usually they present with increased CRP and ESR. If these parameters are normal, it's very unlikely that the cause of the symptoms is due to infection. So it's more than 90% sensitive. However, it has a low specificity. But if you combine this with nuclear medicine studies like the technetium scan, it is, again, very highly sensitive. And you add the gallium scan, it's very specific and increases your specificity to diagnose infection in the construct. So this is an example from the literature of an infection at the construct. You can see the sclerosis here. You can see the loosening. You can see the abnormal configuration at the fusion level. And then when you do the nuclear medicine study, you can see the abnormal uptake. Again, another example here. Again, failure of fusion, soft tissue abnormality on the MRI. And then when you give contrast, you can see the enhancing phlegmon, especially in the soft tissue surrounding the fused level. Accelerated degenerative changes adjacent to the fused level is also another complication. So this example, you can see the fused level here. This is in the immediate post-operative study. And then a few years later, you can see that degenerative changes happen at the end of the fused level. So this is usually as because of the increased biomechanical load due to fusion. It's asymptomatic in 15%, but it may require extension of the fusion. So what about the post-laminectomy syndrome or the failed back surgery syndrome? This syndrome is basically a persistent or recurrent pain after lumbar surgery, and it has many causes. The usual causes is a recurrent disc herniation or epidural fibrosis, spinal stenosis, arachnoiditis, or performing surgery on the wrong level. The way to diagnose that is to do an MRI with and without contrast. So pre and post contrast is very essential to differentiate the scar from the disc. An example of a patient who had a post discectomy at L4-5, and you can see there is a still bulge here at L4-5 following surgery, but when you give contrast, there is a residual disc here. So this is a residual disc disease at that level. Another patient who had same discectomy at L4-5 with a residual bulging on the T2 sequence. But then when you give contrast, you can see that this bulge is enhancing. So this is actually a granulation tissue, not a residual disc. So it's important to do this with post-contrast images. However, just be wary that if you do the MRI in a delayed manner, so if you wait longer enough, the disc will also enhance. So this example here of a residual disc, although it's not enhancing here, but it can take a little bit of your gadolinium if you acquire the images in a delayed manner. So be wary of that. CSF leak is another complication. It's usually presented with positional headaches and usually resolves within 4 weeks. And it can be treated with lumbar drain to aid the closure of the leak. And usually you can differentiate between a true CSF leak or a lymphatic leak by doing a B2 transferrin test. You can test the fluid that you aspirate, and you can differentiate whether this is CSF or not. You can also do CT myelogram or indium 111 cystogram for occult leaks to detect it. So this is an example here of a CSF leak, and you can see the track here. Vascular injury, again, is another important finding. You just need to make sure, as we said, to review the position of the screws. You can see this screw here is traversing the vertebral canal, compromising the right vertebral artery. So in that situation, you should give contrast just to see the integrity of the vertebral arteries. And that patient, that screws was removed and repositioned into the correct position here. So in summary, we just reviewed the common approach to spinal fusion. We had a discussion of the imaging findings seen in arthrodesis and pseudoarthrosis, reviewed some of the most common complications seen following spinal surgery. So with that, I'd like to thank you all for your attention and enjoy the rest of the meeting.
Dr. Russell, excellent talk. Once again, very useful, excellent images. A lot of nice examples. Thank you for that. I'll ask Dr. D.K. Singh to introduce our next speaker.
Yeah, thank you, Dr. Russell, for a nice talk. And now I introduce Dr. Rakhi Kumar Parchuri, and she the Chief Radiologist in GBK Health Hub, Hyderabad, Telangana, and lead MSK Radiologist in Cognizance Private Limited. Okay, she was previously in various hospitals, the assistant professor in Noida, where I live, and assistant professor in Hyderabad. Okay, and she has also received some international ISS certificate of academic excellence by President of USA George W. Bush Sr. And she is the reviewer of national and many international journals. Her talk about just a minute, yeah, her talk about lessons from the trenches case-based discussions to Dr. Rakhi to you.
Hi, Masal Khair, everyone, and I want to thank everyone for inviting me today for the Emirati MSK Society and as well as MSS. I'll just share my screen. Is my screen visible?
Yeah, it's visible, Rakhi.
Yeah, is it? Yeah, okay. So for the last and the final talk, lessons from the trenches, I'm just going to, you've seen a lot of theory and we are just going to review how it happens, how we see these cases in real life. So the speakers before me, Dr. Rashid, he spoke about all the lines. I'm just going to review them once more. I really like, checklists, because I say they keep me in check, because, there's a less chance of you missing the findings. So along with, looking at the basic things, make sure that whatever study is there, it is a complete study and there's adequacy of exposure. Always look at your interspinous lines and make sure that the AVL, the posterior vertebral line, spinolamellar line, and the interspinous line. Make sure that they are smooth on the AP view. Again, look at the lines along the lateral vertebrae and in the spinous processes. When you look at that, look at the bones, the cortical margins, the facet joints, the interspinous distance. Look for any avulsion fractures or any dislocations. Look at the disc, they should be all at a similar height, and look at the prevertebral soft tissues. In the lumbar and the thoracolumbar vertebrae, again, look at the pedicles, the spinous processes, as well as the alignment of the vertebral body. In CT and MR, you have a checklist reporting method. Try and follow it so that there is less chance of missing anything. So let's look at the first case, a very simple case. I'm going to let you look at the findings. This is a CT scan. This was a 24-year-old male who came with us to trauma. So my first question to you is, so this is not a poll question, just think of it. Do you think the alignment is maintained, yes or no? So what are we going to do? We're going to actually trace through the lines. So if you see, the anterior vertebral line is broken, the posterior vertebral line is again broken, and so is the the spinous line. So no, the alignment is not maintained. Let's look at some of the axial images. You can see the atlas, and then you're going to see you can see the dents here. And as you scroll down, you see that this dents is not aligned with the rest of the body. Looking at the coronal images, and clearly this is a simple case. We've seen this before with previous speakers. This is a case where we are seeing a fracture through the junction of the body and the tip of the dents, odontoid process. So this is a type 2 fracture. Again, on sagittal images, the same finding, but what we are seeing here on the sagittal is that you can see that there is a displacement, and this is definitely more than 6 mm. You can even look at soft tissues and you can still see at some ligaments, and you can tell that they are quite intact. This is another case. This is more of a chronic finding, but what I would like to highlight in this case is that look at the risk factors for non-union. If there is a displacement of the odontoid by more than 6 mm, as it was in our case, this is a higher risk factor for non-union if the age is more than 50 years, and if the fracture fragments are comminuted, or if there are any splinter fragments. Let's look at the second case. So this was a 22-year-old male who came with complaints of neck pain since the last 2 months. It was sudden in onset, dull, aching, and aggravated with neck movements. There was a history of trauma 2 months ago. There was no history of weakness in his limbs or any bowel incontinence, but he was now presenting with some complaints of bladder retention. There was no history of tingling or numbness in the limbs. On examination, there were no motor or sensory deficits. His deep tendon reflexes were normal. The plantars were equivocal bilaterally. There was some restriction of the neck movement from side to side. So let's look at the neutral images. And patient, we also performed a flexion and extension images. And what can you identify? You can identify that there is a break in the posterior vertebral line. And when you look at the other images, always remember, I say that the spine is something like the pelvis, where, you have rings. So if you have one fracture, look for other fractures. Same thing in the spine, look for other synchronous fractures. And if you see these images, you can see that there are fractures of the spinous processes. This is a very old case. Before, we used to have packs and we used to click pictures with our camera. So this is an image from the film which I had saved, and you can see fractures going through bilateral pedicles. Along with that, you can also see here that there is some mild forward translation of the C2 over the C3, and there are multiple fractures involving the spinous processes in the lower spinal vertebrae. So this is a classical hangman's fracture. I'm not going to go into details, just give you a little trauma that, hangman's fracture, despite its name, you don't really see it a lot of judicial hangings, where the death is most often due to asphyxiation, and it's never seen in suicidal hangings. This is an MR, and in these cases, because there is a widening of the vertebrae, so any injury to the cord is generally unlikely. Coming to the next case, this is a 25-year-old male patient, history of trauma. What is your diagnosis? So let's go through the checklist. So like I said, let's look at the alignment. Let's follow the lines. There is a break in the anterior vertebral line. In the lower vertebrae, when we go to, through the upper, we can see that there is a break in the posterior vertebral line at the C2 level, and again lower down at 3, 4, 5, 6, at 6, 7 level. And when we look at the posterior vertebral line, we can see that there is a break here. There is discontinuity at C1, C2 level, and again at C6, 7 level. In the AP view also, this alignment is not maintained, so this is lost. Let's look at the bones. The cortical margins are good, so that's okay. Let's look at the facet joints. No, the facet joint, there is a forward translation, and you can see that there is not full contact here. Let's look at the interspinous distance. There is widening at the interspinous distance, and this tells us that there is definitely going to be some injury to the posterior ligamentous complex. Look for spinal avulsion fractures. There are none. Look for vertebral subluxation and dislocation. We already described that. Look at the disc spaces. These are not similar here. And look at the prevertebral soft tissues, which look pretty okay. So this is a case of hangman's fracture with C6 over C7 anterolisthesis, and this had a unilateral facet dislocation. Let's look at the next case. This patient came for some other investigation, but this is a poorly done PNS Waters view. But let's look at it and say, is there any abnormal finding? We are going to look obviously through the open mouth, what we can see here. So is there an abnormal finding? Do you think there is an abnormal finding here? Yes or no? Yes, there is an abnormal finding, and you can see here, there's something not right with the atlas vertebrae. So is it a normal variant or is it a fracture? So this is a non-union of the anterior arch of the atlas. You can see this is vertically oriented in the midline, and you can see that this is it has nice sclerotic margins, and it's superimposing the odontoid process. And sometimes you can misread it as a Jefferson's fracture. Let's look at the next case. So 47-year-old male, he gave a history of fall of a heavy object over the head, and he complained of neck pain. There was weakness in bilateral upper limbs and lower limbs, and difficulty in passing urine. And I want to thank my teacher, Dr. Rajesh Kapoor, who was my teacher during my PG days ages ago. And sir is at the Indian Spinal Injury Center, and he shared a few interesting cases with me, which I'm sharing with you today as well. So let's draw our lines here. What are we seeing immediately? There's a break in the anterior vertebral line. We can see that there's an anterior subluxation of a C5 over C6. And let's look at the facet joints. This is a classical FRCR case. They used to ask in the spotters, look at the facet joints, and you can clearly see here that the facets are what known as perched facets. The interspinous distance is also widened, which tells us there's definitely going to be injury in the posterior ligament complex. So this is a case of bilateral facet joint dislocation, and you will see this when there's anterolisthesis of 50% or more, then there's an increased interspinous distance. These are unstable injuries, and there's a high incidence of cord damage. So the patient MRI was performed for this patient, and as we scroll through the T2 weighted images, you can see that there is some fluid in the region of the odontoid, and you can see that there is definitely anterior subluxation of C5 over C6, which is more than 50%. The cord is looking edematous. You can see that your anterior longitudinal ligament is gone, and there is a discontinuity of the posterior longitudinal ligament as well. There's a retropulsion, and there's definitely cord edema. And as we can see here, we can also see there is widening of the interspinous distance. There's a lot of edema, and probably there is also injury to the ligamentum flavum at this level. Let's scroll down on the axial images. As you go through the axial images, you can not only see the cord edema, but one thing that you must look for is always look for loss of the normal flow void. And this you can see, or from above to down, you can see there's a loss of the normal flow void in the left vertebral artery. There's a lot of cord edema here. There is narrowing of the of the spinal cord. There's a secondary canal stenosis at this level. This patient is definitely unstable. So this definitely needs surgery. So when we place this case in the subaxial graded according to the SLIC severity score, you can see that this is a rotation and a translation type of an injury. When you compare it to the thoracic spine, the distraction injury is graded less. There is definite disruption of the disco-ligamental complex over here, and this patient had a persistent cord injury. So this is a very high grade, and this needs surgical fixation. This is the companion case. We normally don't see perched facets, locked facets in the dorsolumbar spine. This is one of those cases. So case 6, this was a 75-year-old male who had a history of fall at home. And as we scroll through his C-spine CT images, you can clearly see there is some kind of abnormality. And in the midsection, you can see large anterior flowing vertebral osteophytes. So this is a case of dish. And you can see there's a fracture extending through the intervertebral disc process. And if I scroll back, you can also see that fracture is extending posteriorly through the posterior neural elements. So let me go through. Patient came, an MRI was performed, and on the MR, you can see that there is a lot of edema, the posterior ligamental complex. There is injury here as well. You can see that there is a destruction at the break of the PLC complex. There is edema which is flowing through more than 2 vertebral body images, and there is hyperintensities here, hypointensities in the interspinous ligament complex, which is the weakest link in the PLC. And on the MR image, on the STIR images, you can see a lot of edema going through in the posterior vertebral tissues, and there is also prevertebral soft tissue edema. And this is the axial image through this level, and we can see the fracture through the posterior neural elements here. Always look for concomitant synchronous fractures. This patient had a lot of hyperintensity in the disc, which for his age is not normal. So fractures in ankylosing spines are more common, especially we saw cases of ankylosing spondylitis and dish, and you can even see them post a minor trauma. You will see these fractures more commonly in ankspon than in dish, because in ankspon the spine is more osteoporotic, and these are mostly hyperextension fractures, and they're most commonly seen in the thoracic and the cervical spine, and you will commonly see them in the mid-vertebral body level, generally above or below the ossifications or through the disc. This is another companion case where patient is a case of disc, and he came with severe grade 3 wedge compression fracture. Case 7. This was a young male who came with history of trauma, and as we scroll through his T1 and T2 images, you can see that there is a significant wedge compression fracture of L1, but this is not a simple wedge compression fracture, because you can see that there is retropulsion of the fracture fragments. So this makes it into a burst fracture, because there is also involvement of the posterior half of the vertebral body. And as you can see that the PLL, the posterior longitudinal ligament, is elevated, and there is a lot of edema here within the cord, which is going up to T11, and we can also see some hyperintensities on T1 in the anterior epidural space, which suggests that this patient had some associated hemorrhage as well. And as we scroll through the images, we can see the axial images. So you can see I'm coming down. There is also, remember, concomitant. So there is also mild wedge compression fracture in the D12 vertebral body. And as I scroll down, you can see there is an anterior epidural collection. There is significant narrowing. You can see the retropulsed fracture fragments here. And you can even see all the signal intensities in the spine. So this patient definitely had a neurological injury. On the coronal STIR images, you can see there is a lot of psoas edema, and so there was, probably the extension of the injury there. And here you can see that there is also a mild compression fracture involving the L5 superior end plate. So when we grade this fracture, you can say that there's a burst fracture, there is a disruption of the posterior ligament complex. So this is 5, which makes it that we need to have a surgical treatment for this patient. Coming to the last case, this was second last case. This was a 44-year-old male who had a spinal injury 20 years ago, and now he presented with worsening, some new sensory symptoms along with worsening as well. And as we scroll through the spine, you can see that he has multiple fractures of the lower dorsal and as well as the upper thoracic vertebrae. And as we scroll through the spine, you can see that there is hyper intensity in the spine, in the spinal cord. And a same thing on the stir images. There is no history of any recent fall, but there is a, and as you can see here on the three images, there is a holocord syrinx. Same thing on the T2 SAG. So a holocord syringomyelia is, this can expand within the cord, and most commonly it is seen in Arnold Chiari malformations. But this patient did not have any Arnold Chiari malformation. And this is very, very rarely seen in post-traumatic spinal cord injury. And it can be seen in months to years post-injury, and it can occur as a result of obstruction to the CSF flow in the subarachnoid space. So there is a the risk factors which increase the chances of having a spinal cord injury are arachnoiditis, a cord compression, a narrow spinal cord, or a kyphotic deformity. It can be found incidentally in patients of spinal cord injuries or with worsening or new neurological symptoms like this patient. Coming to the last case, this patient came, he had a high-speed motor vehicular accident. The lumbar spine radiograph was done. The lateral looks normal, the AP looks normal. And when you look at the AP lumbar spine, you can see there's a complete transverse dislocation of the spine. And see how, normal the lateral radiograph looks. So that is why we need to always have a minimum of 2 radiographs for anything in, especially in trauma, when you are doing conventional radiology. It's very important. Patient, an MRI was done. You can see that there is a disc extrusion through this, and on the AP, on the coronal sections, you can see that there is a near complete dislocation of the spine, and there is a transection of the spine. Why I'm highlighting this case is because it's a very rare injury. It's only seen, I think, 3% of all spinal injuries. And what is important here, I would like to tell you, is that when you look at the TLS classification, here a complete cord injury is graded lower than an incomplete cord injury, stating that if the patient has lost a complete transaction, but the incomplete cord injury, there it's an emergency and it needs to be treated immediately. The spine needs to be fixed. So that is why I highlighted this case. These are my references. Thank you. And this is my email ID. You can contact me at this email ID if you have any queries. And I'm closing with this image of the, India's win yesterday. I don't know how many of you in the Emirates, saw this, but we were really up, the whole night. I think I slept at 2:30 because there was so much excitement after India won the match. Thank you.
Thank you, Dr. Raki, for the elaborated cases and the rare cases, the simple cases, and you have already concluded all the talks in your cases. Okay, so thank you, Dr. Raki. Thank you so much. Coming to we are closing. We are on the last of the session. So before closing the session, I want to thank all the speakers. Okay, as we conclude today's webinar, I want to extend my deepest gratitude to our esteemed speakers. Each of you have brought invaluable expertise and passion to today's discussions, making it both informative and engaging. Your dedication to sharing the knowledge is truly commendable, and we are privileged to have had this opportunity to learn from you. Thank you once again for your outstanding contributions. I am really thrilled by the possibility that lie ahead for collaboration between the UAE and MSS. The insights shared today have highlighted not only our shared interest, but also the immense potential for mutual growth and innovation. I am confident that by working together, we can achieve remarkable outcomes that benefit both our great nations and contribute positively to our respective fields. Thank you all for your participation and dedication to building a bright future together. Dr. Vijay. To Dr. Vijay.
That brings to an end of an excellent CME session. I would like to thank all the speakers my heartfelt thanks to all the speakers, especially from the Indian counterpart. The the girl gang has done an excellent job, and the speakers from the UAE. Thank you for sharing your expertise and knowledge on this platform. Very exciting times ahead. I hope this collaboration with the Indian MSS Association continues, and we flourish together in the future. And I thank Dr. D.K. Singh and Dr. Jairaj. My deep gratitude for facilitating this, taking all the efforts to bring this to light. And I would like to congratulate both the associations for starting this and uh, taking it further. Thank you, everybody.
May I request Dr. Abdullah Al Rebati for your closing remarks?
Yeah, thank you very much, both society. And thanks for arranging this opportunity. And again, as I mentioned earlier, I'm hoping that this will be a continuous CME between the two societies. Thanks, and I would like to thank all the distinguished speakers for their excellent speeches and their effort. Thank you very much.
Thank you, sir. Dr. Gerard, sir, for your final closing remarks.
Thank you, Dr. Dirmender. And we call him DK. You know, he really drives everybody and gets things done. Thank you very much, Dr. Dharmender and Dr. Vijay, for making this happen. In fact, the title itself says so much that to unlock the secrets of the spinal trauma, we really went and navigated first and then illuminated and then paved the way and to understand a lot of things and consolidated a lot of good bonding and collaboration between the strengths in two countries. I'm very happy that this happened. We have now got access to very good experts in the various fields. The centers where they work are really doing some fine work. And I think the societies by itself must encourage such talent among our countries. It is my only wish that this is continued in the future years to come, and we will take it far by giving all the necessary support and all the kind of collaboration that people would require in this manner. And I'm so happy about this great success of this webinar. It's beautifully conducted. Thanks to Vidocto too. All the team players in Vidocto have done a fine job. We never had any transmission failures or anything. So it is my privilege and honor to be giving the closing remarks. And thanks to each one of you who have participated and to all the delegates who have come online on a Sunday and spent some moments to learn something very valuable. Thank you very much. Wish you all a great Sunday. And we shall now close this particular session. Thank you.
Sir, before closing the session, can become online, sir, so that we can take a group photograph, sir. So everyone can open his camera, all the speakers and Dr. Abdullah, please.
Yeah, DK,
Yeah, that's
just
good. A good idea.
Yeah, Dr. Shruti. Dr. Shruti.
Dr. Shruti?
Yes, sir, I'm here, sir.
Yeah, come on. Yeah, that's good. Very good.
Okay, fine. So I'm taking one. Yeah.
Thank you.
Just
thank you very much.
Thank you, sir.
Thank you, sir.
Very memorable.
And on behalf of Secretary MSS, I want to tell that in every last Sunday of June, one webinar will be happening every year. This is our promise, MSS, to the collaboration between two great nations, and in every last Sunday of June, this different topics. Dr. Vijay will be there, so we will coordinate. Thank you so much once again. Thank you.
Wonderful. Thank you very much.
The recording will be available, I was told, in the archives. So people who had problems logging in, people who have registered will have access to the video. So which is a good thing.
And thank you, Dr. team. And the certificates with CME points will be emailed to every speakers and every delegates by the Dr. team in due course of time. Thank you. Thank you so much.
Thank you.
Thank you.
Thank you, sir.
Sir, shall I conclude the session?
Yes, please.
Thank you, sir. On behalf of organizing committee and from technical partner Vidocto, we thank everyone for being part of this webinar. As a part of webinar team, this is Shweta and Sumit signing off. Wishing everyone a very good day. So, with your permission, may I end the session?
Yes, Shweta. Thank you.
Thank you, sir.